Good morning, everyone. Welcome to the E. Richard Brown Symposium. I'm Dr. Michael Drake, President of the University of California. First, I want to thank you for everything you're doing to serve patients, conduct health research, and advocate for a better and more inclusive healthcare system, all in the midst of a global pandemic. Your dedication and commitment during this challenging time is saving lives and making the world better. This gathering is taking place at a pivotal moment for our state and nation as we manage the profound health and economic impacts of COVID-19 and have a national dialogue about systemic racism in our communities. Since March, COVID-19 has exposed deep pre-existing inequities in our society and in our healthcare system. We've all seen the disproportionate impacts on the Black, Latinx, and Native American communities, on service workers, in rural and immigrant populations, individuals in correctional facilities, and more. And we've all seen these inequities in healthcare delivery and access for many decades. I've seen them as a medical doctor, as a faculty member, and in my current role. Some of the programs that we have launched at the University of California, such as the PRIME program, were created specifically to address these inequities. And we've conducted research that shows the value of diversity in medical education for the quality of education, the quality of research, and the quality and breadth of service provided. As health policy leaders and medical professionals, as advocates and as citizens, we must recommit ourselves to examining our healthcare system through the lens of social justice and equity. UC Health Centers have always been an essential component of California's safety net. We provide excellent patient care to many of our most significantly underserved populations, but there is much more we can do. The theme of today's symposium, Healing a Fractured Society, speaks to the urgent and far-reaching nature of this work. It expands far beyond the healthcare system to broader systemic structures in urgent need of reform. I hope this theme will serve as an organizing principle for your discussions today. I also hope that it will serve as a call to action. I know that the namesake of this symposium, Rick Brown, would support that. Rick was a UCLA professor and healthcare reform pioneer. He had an extraordinary ability to leverage public health research into on-the-ground efforts to expand healthcare access and coverage. This is a difficult time for many of us, but we must seize this opportunity to improve health equity and access for the next generation of Californians and Americans. Thank you for working to make this vision a reality. Enjoy the symposium. Fiat Lux.
Hi, everyone. Good morning. It's Ninez, Ponce. 1 second, we're having issues with the video, but let me just get started as that's happening. And then when the video tech issues get fixed, you will see me. So good morning here on the West Coast. I'm Ninez Ponce, Director of the UCLA Center for Health Policy Research. I serve on the faculty of the UCLA Department of Health Policy and Management in the Fielding School of Public Health. Welcome, welcome policymakers, students, researchers, alum, colleagues, faculty, and friends. It is a privilege to have you, I can start it now, 1 sec. Hello again, welcome. It's such a privilege to have you join us at this year's important and timely symposium. UCLA is a land-grant institution, and here we open each event by paying respect to the Gabrielino Tongva peoples as the traditional land caretakers of the Los Angeles area and South Channel Islands. Let us all honor and acknowledge the painful history of genocide and forced displacement of indigenous peoples still connected to lands where we all live and work. 2020 is not what we imagined it would be, and 2021 is anyone's guess. We are in the middle of a devastating pandemic that has further exposed the fractures and inequities in our society. Healthcare remains a privilege rather than a right for some people, and racism is a systemic and ingrained crisis and public health challenge. We find ourselves at an inflection point in the midst of outsized challenges. Our symposium in honor of our founder, E. Richard Brown, has never been more relevant to the themes of healing our fractured health system. Rick, as we fondly know him, was an extraordinary leader, scholar, mentor, and friend. He was a professor at the Fielding School of Public Health and founded the UCLA Center for Health Policy Research in 1994. He passed away to our enduring sadness, yet his work and impact not only still heavily influences California today, but extends nationally as well. While it is difficult to pick just three today, the center is best known for providing comprehensive data on the health of Californians through the California Health Interview Survey, known as the CHIS, a valued resource for health leaders everywhere, often cited by policymakers, patient advocates, and health system reports as evidence for policy and program decisions. Rick started CHIS 20 years ago, filling the gap for community-level data he experienced early in his career. It remains an authoritative resource as we are constantly updating the content to capture the most important information needed by healthcare leaders. And we harness the best survey science to ensure the data truly represents California's diverse racial and ethnic population, as well as the unique communities with special health needs. We are also known for developing innovative tools, highly valued by policymakers. Two examples are the Elder Index, used to understand the unique economic issues facing older adults, particularly in a high-cost state like California, and the implications for their health and healthcare access. And CalSim, a microsimulation model used to estimate the impact of various elements of the Affordable Care Act. These tools join our award-winning query system, Ask CHIS and Ask CHIS Neighborhood Edition, designed to realize Rick's vision that data doesn't just sit on the shelf, rather it is made accessible and easy to understand by even the least technical user. Already this year, those systems have made well over 90,000 queries. Finally, we are known for our outstanding faculty and staff. They develop relevant studies, such as the Right Study, which expands our understanding of how the experiences of Asian and Latino immigrants impacts their health and access to care. And we conduct valued evaluation projects, such as the informative review of California's Whole Person Care pilot program, reviewing efficacy and cost effectiveness of local initiatives in coordinated care delivery for high-risk populations. And while we have a long history of producing high-quality research studies and evaluations, we are also nimble enough to pivot quickly to emerging issues such as COVID-19. The Whole Person Care evaluation put a spotlight on the program's response to COVID-19. And while still publishing business as usual, more than 20 policy briefs so far in 2020, our team also channeled our skills to address important issues brought to light in the pandemic. For example, we used our data generation skills to highlight the pandemic's impact on the Native Hawaiian and Pacific Islander communities, often invisible in most health data systems. Their members serve in significant numbers in essential jobs and make up a disproportionate number of those affected by the virus. We have already launched dashboards tools on the information on Native Hawaiians and Pacific Islanders. In fact, this is just one of four COVID-19 dashboards we've created for sharing crucial local level information on racial ethnic populations for communities to fight this pandemic. This is not the first time we've responded quickly to a public health need. In 2018, we conducted rapid data analysis to address another timely issue, ultimately providing groups across California the data needed to understand the impact to California of the so-called public charge rule proposed by the federal government. Working with the Berkeley Labor Center, California food policy advocates, we demonstrated the toll the proposed rule would have on California's economy and healthcare workforce, and ultimately on the health of some of our most vulnerable residents. The study was cited by dozens of organizations and public officials filing comments in the Federal Register. This work is just another example of how our work extends outside the state boundaries. And Rick, in his desire to help not just California, but all states to build a high impact evidence base for their own needs, started the National Network of State Surveys. As part of this work, we are launching a workshop series on improving the disaggregation of race and ethnicity categories in health data resources across the nation. We know this information is key to building equity in our healthcare system. I am honored and proud to work with such a talented team at the center. You don't need to take my word for it. Our values demonstrate a commitment to producing high quality, actionable data and evidence that drives change with the goal to improve health for every individual in our communities. We started the symposium series last year with the generous support of Rick's wife, Marianne, who I hope is in the audience right now. Last year, we held 2 days of panels and discussions in both Sacramento and UCLA about the potential for a healthcare for all model to be implemented in California. The event brought together international experts in universal health coverage systems, state policymakers, healthcare leaders, advocates, and researchers. The exchange of ideas and consideration of ideas among thought leaders is the kind of event we feel is especially valuable to find calls to action to address critical health issues, such as we are preparing to do today. And as always, we engage students who are the future health and policy leaders to help shape the dialogue and really envision the future of care. We look forward to having the E.R. Brown Symposium as an annual event. The center could not be where it is today without the support of the School of Public Health, thanks to Dean Ron Brookmeyer, who is joining us today. The center also benefits from and fosters incredible partnerships and collaborations with others across the University of California and beyond. We also appreciate the partnership and support from our state and county partners, foundations, community organizations, and others who are committed to solving many of California's pressing problems. As we think about the impacts of COVID-19 and where we are today, through the vital tools of scholarship, data, and evaluation, we see many of the fractures in our health system and society at large laid bare. The impacts of these fractures deriving from racism, inequality of opportunities, barriers to quality care and public health. These are the ones that sap our communities of vibrancy and well-being. The pandemic has made many of these challenges painfully obvious. How will we address them? How will we heal? I hope today's symposium, kicked off by President Drake, will get us all thinking and coming together and embracing evidence-based policy solutions to these hard questions. We are delighted to welcome two fantastic panels today. We are fortunate to have national expertise and California leaders join us with two terrific moderators who are my esteemed colleagues at UCLA. Michael Rodriguez, Professor of Family Medicine and Public Health, and Mark Peterson, Professor of Public Affairs, Law, and Political Science. You can read the full bios of our moderators, panelists, and speakers in the program. So with that, thank you again to President Drake. Again, thank you for coming back to UCLA and becoming our leader during this important time. Again, to our panelists, our sponsors, the School of Public Health and staff for putting today's symposium together. I especially want to thank the two panelists who are doing double duty as moderators for these upcoming panels. I thank each of you for being here today and look forward to a productive and vibrant discussion. So, Michael Rodriguez, please launch the first panel discussion.
Good morning. Let's make sure we all, thank you so much, Ninez. I appreciate your kind words. And as I also appreciate the inspirational words of Dr. Drake. And welcome again to our panel entitled Putting Social Justice and Equity at the Front Line in Healthcare. I'm overwhelmed, as I'm sure many of you are, to be here at this moment, this extraordinary moment, new friends, old friends, all coming together with a recognition that this moment has significant transformational implications. We put this first up because we feel that that social justice and equity have a vital role in our response to all that's happening. All that's happening, well, there's no way for me to capture all of that in a brief overview, but as context, I'll say a few words, starting with the more than 38 million people who've been diagnosed with COVID-19 around the world, and more than 1 million people who've died. In the United States, greater than 216,000 people have died, thousands reported to be preventable due to mishandling of the pandemic. In the wake of COVID-19 and its direct impact on the world, we find even greater impacts on particular populations, including Latinos, African Americans, Indigenous, and other historically marginalized groups. While there are significant health, mortality impacts, the pandemic has also resulted in simultaneous economic and educational crises, which are also unequally distributed. These are happening at a time when we have a reckoning with the multiple criminal justice inequities and structural discrimination that have historically been directed towards African Americans, Latinos, immigrants, and other groups, sometimes manifesting through police killings, other times systematic attacks and fear-mongering of immigrants, including human rights violations being committed on immigrants by the US Immigration and Customs Enforcement, such as the removal of children from their parents, detention in crowded refrigerated cages, and performing non-consensual surgeries, such as hysterectomies, while in ICE detention. Meanwhile, there's continual efforts to overturn the Affordable Care Act and threaten access to care for millions of people. Federal expansion of the global gag rule is another example of our impact beyond our borders in using, that has been described as using foreign assistance to limit global sexual and reproductive health rights. The devastating effects of climate change can be seen quite easily here in California and beyond, manifested by the California Zog fire, which killed 4 people, burned more than 50,000 acres, and today was reported as contained. This fire is one of over 8,000 fire incidents that burned a record 4 million acres and claimed the lives of 31 people this year. We add a census that's recently been shortened and supported by the Supreme Court with enormous implications with regards to political and economic impacts, contentious efforts to confirm a conservative Supreme Court justice, historic articles from prestigious journals, including Nature and New England Journal of Medicine, about the impacts on science. Meanwhile, a nation election underway with long lines encountered, online voter registration sites crashing, and trash bags of undelivered mail being found, stoking distrust in the US Postal Service. These structural inequalities are magnified due to the multiple crises that are happening and are a frame the work that we need to do. The racial, ethnic, immigrant, gender, homophobic, and other inequalities promoted through policies call for strategic actions to dismantle these inequities and replace them through our collective activism and advocacy. Hence, social justice and equity are our goals, working in partnership with communities, leaders from the grassroots who daily show us about bravery, justice, activism, resilience, innovation, and ideas for making healthier communities. One of our most important responses to the inequities and injustices includes social movements driven by communities, including those for immigrant, racial, gender, climate justice. In fact, just this morning, I heard of a new coalition of mayors for Medicare for all, founded by Oakland Mayor Libby Schaaf, along with Mayor Robert Garcia of Long Beach. Thankfully, we have some great global leaders on this panel that will help us with the response to Dr. Drake's call for action. It is my great honor to introduce each friend and colleague in the order in which they will present. We will then have a discussion between the four of us and address audience questions as well. Our first speaker will be Dr. Sandro Galea, who is Dean and Robert Knox Professor at the Boston University School of Public Health. Our second speaker will be Nadine Gracia. Dr. Gracia is Executive Vice President and COO of Trust for America's Health. And Dr. Sandra Hernandez, President and CEO of the California Healthcare Foundation. On that note, please help me to welcome from our virtual places, Dr. Galea.
Thank you very much. Can you hear me? Excellent. Thank you. I'm Dr. Rodriguez. Thank you, Dr. Ponce, and thank you to the Center and UCLA for inviting me to this and for asking me to make a few remarks. I'm going to keep my remarks fairly short because I mostly am interested in the conversation with my good colleagues. We are living through an unprecedented time. We are living through a moment in history which we will all remember and we hope not to live through again. And there are many stories to be told about this moment. There will be much to be discussed in years to come. But I think the central story of this moment is the story of how the story of COVID-19 has been written unevenly across populations, about how the burden of the moment has been borne unevenly by different groups. And that story, to my mind, is best told through a story of understanding the uneven burdens falling on people with different socioeconomic position and on people of color. There is abundant evidence that people who are poorer, more unstably housed, who have fewer assets to begin with, who have less wealth, are the ones who have been borne the burden of COVID-19 much more than others. And there is abundant evidence that that overlaps substantially on people of minority, racial, and ethnic groups. We know, for example, that Black Americans currently have about 2.3 times the death rate of white Americans due to COVID-19. Now, these facts, I think, are becoming well known. They're out in the public conversation, which is a good thing. What I think we have not done enough is thought carefully why this is. Unfortunately, there is nothing particularly surprising about the social, economic, racial, ethnic patterning of the consequences of COVID-19. This is patterning that has been the case for decades and centuries before COVID-19. COVID-19 has elevated, clarified, and sharpened things that we already knew. So while we have had a disproportionate burden of COVID-19 falling on these groups have had a disproportionate burden of poor health on all axes for decades and for centuries. Insofar as about 20,000 Black Americans have died on COVID-19 simply because the rate of death is so much higher than it is their white counterparts. That's just the excess mortality. We also know that hundreds of thousands of Black Americans die over decades because of overall Black mortality being higher than it is among white Americans. So to my mind, at a simple level, I can say COVID is not telling us something we did not know. At another level, COVID is taking what we knew and elevating it and sharpening it. And I think this is our moment to make sure that we do not forget what COVID is teaching us and to make sure that the entire world does not forget what COVID is teaching us. In a moment like this, I'm often asked, so what's the silver lining? Well, there is no silver lining in the context of lives are being lost, people are dying unnecessarily. But if we are to honor that memory, I think the best thing we can do to honor the memory is to do exactly what we are doing here, which is to have the conversation, to surface these issues, and to make sure that the deep underlying foundational differences in achievement, which maps onto health achievement for groups that are characterized by having fewer assets and are marginalized by virtue of their race or their ethnicity, is fixed once and for all, so that health and flourishing is available to everybody, commensurate with their effort and their interest in how they want to engage with the world. I'll stop there.
Thank you so much, Dr. Galea. Dr. Gracia?
Thank you, Dr. Rodriguez. Can you hear me? Great. Well, good morning and good afternoon, everyone. Again, my name is Nadine Gracia, and I serve as the Executive Vice President and Chief Operating Officer at Trust for America's Health. It is such a pleasure to be here with all of you. I want to thank Dr. Rodriguez and Dr. Ponce for the invitation to participate in such an important conversation and symposium, and to do so certainly for an academic institution in my home state where I was born and raised in California. It's truly a pleasure, and to be joined with such esteemed panelists in this conversation. You know, I echo and concur with Dr. Galeo's sentiments and statements about how the COVID-19 pandemic is certainly shining a bright light on long-standing systemic inequities that our nation has faced. These disparities certainly have been described for more than a century. We can look to research that has been done, evidence that has been shown with regards to disparities that disproportionately impact people of color and communities for far too long. I formerly served in federal government, and even from a federal perspective, we have known and understood these disparities. This year is also the 35th anniversary of a landmark report, the report of the Secretary's Task Force on Black and Minority Health that was issued by the U.S. Department of Health and Human Services in 1985, really based on the advocacy of communities, based on the advocacy of leaders, such as leaders in historically Black medical colleges and universities, who called for the federal government to do a comprehensive study on the health status of racial and ethnic minorities, not because it was not known that those disparities existed, but really to champion and further drive efforts to be able to end those disparities. And certainly what that report found were the significant differences in health status and outcomes for people of color across the country. It led to important changes and really catalyzed putting minority health onto a national stage, with leading to legislation and infrastructure, creating, for example, the Office of Minority Health at the U.S. Department of Health and Human Services, inspiring and catalyzing states to create offices of minority health across the country, but having legislation that also addressed funding, addressed research and data, because one of the things that the report found and that advocates saw was the dearth of data, for example, for certain populations of color, such as Asian Americans, Native Hawaiians, and Pacific Islanders, American Indians, and Alaska Natives, and the Latino population, and led to the creation of some organizations that said we need to take action on these issues, especially if we see the dearth of data and really a recognition of the disparities that exist in our communities. But what we know, if we fast forward 35 years, is we're continuing to see, even despite some of the progress that has been made, is the continuance of these disparities that, as Dr. Galea noted, these are really rooted in structural inequities. Even in the National Academy's report in 2017 noted that these health inequities, they're not due to individual choice or some random occurrence, but rather really due to inequitable policies and structures and norms that we have created that are shaping people's lives. And so it should be that indeed the COVID-19 pandemic really should be a clarion call for action. We have had waves and cycles of investment, of dedication and leadership in addressing health equity. But this should be the call that for once and for all, that we firmly commit to advancing health equity for the nation. We know that, for example, our nation is spending about $3.5 trillion annually in health spending, but less than 3% of that goes to public health and prevention. A large proportion going to healthcare, which is important, but the underinvestment in public health is clearly on display now. That we need to truly invest in, support, and create that 21st century public health system that is so vital to helping to promote the conditions that communities need to actually have opportunity for health, that there are far too many structural barriers that exist that create those inequities. And that those inequities actually exist across systems, not only in healthcare and in health broadly, but in education and in transportation and housing and food security. And so this is also an opportunity for us to think about modernizing our public health system, strengthening the opportunity for us to really work in a multi-sectoral, multidisciplinary fashion to be able to ensure that everyone has a fair and just opportunity to reach their full potential for health. Far too many times we have come out of a public health emergency where we have been inundated and flooded with the opportunity of being able to address these systemic inequities, and yet we have not fundamentally changed those barriers. And we see this repeated, but the COVID-19 pandemic really cannot be ignored. And so I look forward to the conversation that we'll have about transforming really health and opportunity so that everyone has the opportunity to thrive, and ensuring that this moment, which has truly been devastating for the nation and for the world, really serves as that opportunity for transformative change that leads to systems level, sustained, and important change for our country.
Thank you so much, Nadine. Dr. Hernandez.
Good morning. Very nice to be with all of you this morning. I want to thank Dr. Ponce for continuing to keep Dr. Brown's legacy alive with such an important conversation that we're all having this morning. It's a pleasure to be with the panel. Building on Dr. Galeo's remarks, this notion of the systemic nature of racism and its impact on low-income communities, and particularly communities of color, it seems to me we are at a moment where, while we have documented with data, Chiz and others all across the country, of various disparities in hypertension, coronary artery disease, obesity, all of the chronic conditions and burden of chronic conditions that have existed in this country for decades and decades. Those are all metrics that we have measured over a long period of time. What I think COVID-19 has done is brought into light the notion that, notwithstanding the many programs, safety net programs, targeted programs that we have put together to try to address these chronic inequities, what I think COVID-19 does for us is really give us a disruptive moment to recognize that for all the programs that we have, if you look today at just trying to apply for unemployment insurance, wildly inadequate data systems and eligibility systems, we have built a set of programs to address the very conditions that we have all been concerned about, and COVID-19 exacerbating that by many hundreds of millions of lives. And yet those programs that we have built largely are full of friction and administrative burdens and hurdles that make it very difficult for the very people, families, and communities that we want to access them to be able to do so. We built programs that are fragmented, that are vertical in nature, that don't actually look at the whole person. I mean, the notion that we have a whole person pilot in California, which UCLA has done an amazing job in evaluating, we at the foundation's been happy to support. Why would we be piloting the notion of whole person care? Why did we build separate financing systems for behavioral health and for physical health? We have perpetuated, by virtue of these systems that we've built, programs that make it incredibly difficult for the very families and individuals and communities that we are trying to reach to be able to reach them. And, you know, as the speaker before mentioned, Dr. Gracia, 18% of our GDP, and when a pandemic breaks out, we don't have enough PPE for our frontline healthcare workers. In California, when we looked at contact tracing, a basic core public health function, less than a third of our counties had anybody in the county to do contact tracing, to Dr. Garcia's point of the vast lack of investment that we've had in public health and public health tools, which we all know historically have been the tools by which populations have been able to thrive. So it is a moment of disruption. It's a disruption in the way we deliver care. I mean, COVID-19 essentially closed down emergency rooms. We rethought what we could do at home versus what we can do online. We're having to consider whether universal broadband is a tool by which we actually get to the health outcomes that we are all trying to reach. We are really having a reckoning of all of these policies and programs that we have built that really are deeply fragmented, and largely because, unlike our lessons from public health and Dr. Galeo and his team at BU, who I follow quite religiously, these are programs that fundamentally need the input of the people we're actually trying to reach. Until we build systems that are consumer friendly, that allow people to enroll in SNAP and Medicaid at the same time, that don't create unnecessary burdens and hurdles for people to access them. That's what we mean about systemic racism in our need to reassess where we are in those programs, all well-meaning. All well-meaning. As 4 million people lost their jobs in California alone, unable to get unemployment insurance. One of few developed countries that has paid family leave for the people who need it most. Imagine if everyone who had a child in this country could take 6 months or a year to bond, to breastfeed, to be able to make medical appointments, to get their children immunized, as opposed to having to go back to work with uneven hours and schedules, trying to piece together childcare and all the data and science that we have on adverse childhood experiences and the stressors that happen in those families that we all know lead to the same chronic conditions that in this epidemic and pandemic we have seen have been a vulnerability point in addition to all the other things we have talked about this morning. I think it's a moment of disruption and of reckoning. Race relationships in this country, conversation is open. We're having it. And the programs and policies that we have promulgated to support our most vulnerable in our communities need us to reassess them. Today in California on the ballot, people are voting on Prop 16. 25 years of banning affirmative action in the state of California, one of the most diverse states in the country. And our healthcare workforce doesn't remotely look like the people that we are trying to serve after 25 years. 45% of the population is Latinx, and less than 5% of them are physicians. And the same is true in pharmacy, and it goes on and on. We have a moment of disruption and of reckoning, and it's time for us to reassess all of those programs, how they work for the most vulnerable, and look at the fact that these are intersecting issues. We have a massive homelessness problem in the United States and in California in particular. These are not problems we will solve one-off. We need to be able to look at all of the policies, how they layer on each other to be able to promote healthier communities in our country. I really look forward to the conversation we're going to have as a group. Thank you, Michael.
Thank you, Sandra. As usual, you deliver, and appreciate that. And I'm going to ask the other participants, other panelists, Sandra and Nadine, to unmute yourselves so we can have a little discussion. You all have sort of provided different parts of this story. Some of the pieces that you provided are the current contexts, past historical important events that serve to exemplify what we have done and what we can do, and also pragmatic issues of today as we address these different systems that are different sectors that contribute to health in that determinant of health framework, whether it be housing, whether it be work, whether it be education, whether it be transportation. I think Nadine was talking about the first person to bring up the issue of structural elements, structural determinants. And so on that note, and that note that was carried by Sandra, I want to ask you all, there are so many different roads that we can go down, and many different that we need to go down. What are your top policy interventions, particularly those that focus on structural determinants, either at the federal, state, or local level, that you're seeing as important ones that we need action on in short or longer term?
Well, Michael, I'm happy to start. One of the efforts that California has just begun to roll out, and I'm sure you and the team at UCLA are deeply aware of, is this equity metric for safe reopening under COVID-19. This is a really interesting tool in the spirit of data that drives, hopefully, a reallocation of resources to where we most need them, which really says you can't sort of roll up averages in a county and say you are meeting the testing rates, the hospitalization rates for COVID-19, and yet have a zip code sitting in the Mission District where you've got COVID positivity rates and mortality rates that are fivefold 2 zip codes away. And what it does is it requires that the public sector and the private sector focus on those areas and places where, for overcrowding, nature of work, language access, fear of public charge, anti-immigrant sentiment, all of those reasons at play require that the public and private sector, if we are going to safely reopen, need to target resources in order to be able to safely reopen in a COVID-19 arena. And I think it's a very interesting model to look at. You could use that equity metric, by the way, on any chronic disease. And so the state promulgating that, I think, is a tool when everybody's interested in safely and quickly reopening, does actually point at what you need to do in those very neighborhoods where systemic racism and all the systems that we've talked about have led to significantly disproportionate morbidity and mortality related to COVID-19. So I think that's a very good use of data that reallocates in real-time resources where people are deeply motivated to do so. And I think that's a very useful tool.
Sure, that sounds like a great idea. I'm curious what the other, what Sandra and Nadine think about this this metric, and where we go from there.
Nadine, why don't you go first?
I think advancing an equity metric such as this is critically important and demonstrates California's leadership as well into recognizing the disproportionate impact of this pandemic on communities and the intersectionality, as we said, of race and ethnicity with socioeconomic status, with geography with regards to looking at neighborhood resources and really painting a holistic picture of communities and understanding the impacts that means for communities as economies are reopened, as businesses return to a status of being in person, to not see a disproportionate impact, in particular on communities that have long been marginalized, that have long had underinvestment and a lack of resources in communities. And I think that as we, part of the challenge, even as we were working to identify communities that are disproportionately impacted, others have said this as well, it wasn't a surprise that communities of color, low-income communities, certain immigrant communities, for example, would be disproportionately impacted. But the data still inform the policy. It informs the direction of resources. And so similarly, as we think about not only sheltering in place policies, as we think about reopening policies, that is also critically important as well to help drive evidence-based and informed policies so that certain communities are not disproportionately impacted because of those policies.
Awesome. So we've got great ideas, potentially driving policies. What do you think, Sandra?
I agree with everything that Hernandez and Gracia said. I suppose three things just by way of framing. Number one is, I do think that one of the most important things to emerge from this moment, and I think this was reflected in my colleagues' comments, is changing the conversation. It is making it clear that there can be no help unless we fix underlying structural, socioeconomic, racial, ethnic differences. And I think the tool that Hernandez was referring to is one piece of that. So I'm folding it into the larger rubric of changing conversation. And I reflected on this a little bit in my comments at the beginning, Michael, where I said, I think one of the most important things we can do is have these conversations. So that's number one. Then number two, Michael, you were asking about policy, what should we do? And I suppose the way I've been organizing these in my mind is in the bucket of assets and stressors. Mm-hmm. Policies that can actually equalize assets and policies that can equalize impact of stressors, again, along socioeconomic and racial lines. So when you think about those two broad categories, let's think about assets, for example. I don't see a way, and I just had a paper that came out this week with my colleague, Dr. Mary Bassett, in which we can actually, in any short period of time, narrow asset gaps, for example, between Black Americans and white Americans, without some form of reparations for centuries of missed opportunity for accumulating family wealth. So I would then consider a policy that considers Black reparations to be something that actually goes towards narrowing asset gaps that way. I'm using that as an example. Similarly about stressors, I don't see a way to narrow gaps in stressors experienced by people of different socioeconomic groups or racial ethnic groups without social safety net policies that buffer, for example, people's differential risk of eviction. So I think we can think of policies in those two buckets as policies that equilibrate asset gaps and that equilibrate gaps of vulnerability to stressors. And I think if we did that, we stand a chance at narrowing socioeconomic gaps and racial ethnic gaps that map out into haves and have-nots, which become health haves and health have-nots.
Michael, if I could return to the...
Oh, no, go ahead, please.
Oh, thank you. I was going to return just to the policy piece. So, in addition to talking about the equity metric, but the policies in particular that we advocate for, certainly at Trust for America's Health, we just last week released a blueprint for a healthier America, specifically for the 2021 administration and Congress. Regardless of which administration that is, we are a nonpartisan organization that advances evidence-based public health policy to really strengthen and modernize the public health system. And in doing so, really advanced 5 thematic areas, which I think really align to both what Dr. Ninez and Dr. Galeo have described, which is one, that we need to really increase and sustain investment in strengthening and modernizing the public health system. There's a leadership forum that we participate in that documented that we have really a $4.5 billion annual gap with regards to public health funding for the core public health foundational capabilities. This is just for infrastructure to be able to do things such as surveillance and have laboratory capacity, to do the community partnership building that is so critical, especially when we think about racial inequities in communities of color, to be able to do the policy development and communications. So really just the foundational public health infrastructure. Secondly, we put front and center that it's important that we commit to and really have a comprehensive effort to ending structural racism and advancing health equity. And that entails looking at, as has been stated earlier, these policies, these structures that are drivers for health, but that actually are causing and creating these inequities that we have seen for far too long. We also, thirdly, talk about addressing the social determinants of health. And I think that we've long talked about this. This is an area that we need to focus on when we really think about root causes of health inequities, and poverty certainly being one of the structural drivers of that. And so how do we actually not only create greater awareness, but actually have investment in addressing those social determinants of health, the inequities that we see in social determinants of health. Fourthly, we talk about the importance of really ensuring the nation's health security. And here in particular, to see how health is really in everything, and it is a critical part of our nation's security. It is not a competing factor to say it's either health or the economy. It's actually both and so ensuring that we actually have the investments to actually promote our nation's health security. Because again, these public health emergencies disproportionately impact communities that have largely been under-resourced for many, many decades. And then lastly, it's to also institute ways in which we can actually ensure health across the lifespan, because we see factors from childhood through older adults that really actually exacerbate poor health outcomes. And so how we actually invest in and create the conditions, whether it's in education, in housing, and other areas, to be able to ensure that across the lifespan, the population actually has the opportunity for health. We importantly noted that racial equity is essential to this. It's essential to the future of our nation, and that racism is a public health crisis, and that without dismantling structural racism, we will continue to see these inequities existing, because it is at the core and fundamental issue with regards to these systemic inequities that we see for our nation.
Thank you so much, Nadine. That the blueprint, that TIFA blueprint, will be extremely important in helping to inform the work of the next administration. Sandra, did you have some other comments?
I was just going to build on something that Dr. Galeo was referencing, which is in this notion of assets and stressors. Assets really do matter, as we've all been speaking to this morning. And I just wanted to call out another California innovation in this space that I think is worth evaluating and understanding how it plays out. The mayor of Stockton has introduced the notion of universal basic income. The notion here was really quite simple. The nature of work is changing, and it is going to continue to change. And so as we think about the economic opportunities for communities that have been historically disempowered by virtue of policies and systemic racism and the like, there's early evaluation on universal basic income in Stockton in terms of what those dollars were used for by these very low income families in Stockton, where the poverty rate is north of 45%. It is notable, the principal uses to date of universal basic income for those families was to pay for food, and was to pay for out-of-pocket medical costs. Most of these individuals are enrolled in Medi-Cal, our Medicaid program in California. And so thinking about the asset base that give tools to families to begin to grow assets, I think is a very critical part of dismantling these systemic issues around income inequality that is so profound and extreme in our country. And it's something that I think data and evaluation over time ought to be looked at. It's been talked about in various debates, usually in pejorative ways, but I think it speaks very much to the point that Dr. Vallejo was making, which is what are the, and there's other folks that have recommended not necessarily cash assets, but assets of land and of giving land to our African-American individuals who have been systematically disenfranchised by virtue of access to housing and redlining and the like. So it's another California experiment as a matter of policy that I think is worthy of our attention as we think about that building of the asset base that's so important in this structural and systemic way of thinking about how to redress systemic racism.
Thank you, Sandra. That is an excellent example of this disruptive innovation that you were referring to. And of course, California taking its role. Sandra, you've done lots of work sort of not only nationally, but internationally. And my recollection is that these policies such as this have not only been started in Stockton, but in other parts. Do you have some words to share on this point?
Yeah, I'm delighted that Dr. Hernandez referred to Stockton experiment, and I'm often asked this question. So, what's the one thing we should do? So, like if you outline the problems, one thing we should do, and my general answer is, I'm not sure that there is one thing we should do, because for a variety of reasons. Number one is the solution to centuries of structured society, which is structured in such a way as to disadvantage people along socioeconomic lines, along racial, ethnic lines, is never going to be any one thing. That's number one. Number two, if one thing is good, two things is better, three things is even better, and four things is even better. So the more policy solutions we have, the better. The third point is, the reason I was offering sort of a way of thinking about it in terms of assets and in terms of stressors is because I think there can be any number of interventions within those buckets in different jurisdictions that can be that can work in some places and not in others. So let's take universal basic income, which Dr. Hernandez raised. That was actually on my mind, and I just didn't speak it, just whatever in the way my sentence went. There's evidence, it's mixed evidence about universal basic income in different contexts. There was a very good study ongoing in Ontario, Canada, which then was stopped when there was a change in government. Can universal basic income be part of the armamentarium of policies to equilibrate assets? I'll tell you for the record, since it is being recorded, I think so, but I also think the data are still emerging. I made reference, for example, to Black reparations. There are, when you read people like Professor Darity, who's written on this extensively, there are many different ways of doing that. I don't know which one is the best way of doing it. I think each of these could stand interrogation, study, and figuring out what works for the local context. What I don't want is me saying the sentence, well, we don't know fully which one will work best, to be a reason for paralysis. I think we can simultaneously have the humility to say that there may be different solutions that work better in different contexts, and to say we know enough to know that we should act on these actions and implement particular things in particular ways, in particular contexts that can advance creating the kind of healthy world that we want. And I think the Stockton UBI experiment is a really nice example.
Excellent. I appreciate those comments and particularly your pragmatic, if I could say, sort of suggestion that we don't hold on, like many of us academics sometimes do, to waiting until we have enough data, right? We'll always, and having more sort of the long view, realizing that there's an urgency to act. There's an urgency to act on models that are reasonable right now, and to continue to work with them as they evolve, and then learn as we do. Nadine, any thoughts on that or related policies?
Absolutely. I think you don't want to create inertia because you're saying that we need additional evidence. I think there is enough to act. And certainly one of our areas of focus is then how do we take what we see works and build on the evidence that works to bring it to scale and to ensure that it then has sustainability. Far too often we see that there are initiatives or ideas that are presented, and even from a policymaker's perspective, which might start and stop, but there's not a long enough investment in those opportunities. And often that can be because of the periods of time that elected officials or others are serving in their positions of wanting to see changes in whether it's health outcomes or other types of health outcomes in a 2 to 3 year period, recognizing, as everyone has described, that these are inequities that have existed for centuries. And so we certainly want to act with urgency, but we also need to recognize that there's a need for long-term and sustained investment to do so. We also have to recognize too that sometimes the outcomes that we're going to see may not be specifically in health initially, but may be tied to other sectors, and recognizing that that is still a valued investment. I think part of our effort is really ensuring that we're educating policymakers to that, to those points, and ensuring that we don't have just a repetitious cycle of seeing these shorter term investments when we really need to have the long-term investments that are based on the available evidence that really then help to inform broader strategies. And I agree that it's not always a one-size-fits-all type of approach, that we have to work hand in hand in community and really have community leaders and members at the table in the decision-making process, those who are affected and understand the needs of communities so that they can be tailored and adapted to the needs of communities. And that may differ depending on the communities. But it's always important to have that voice and that empowerment and meaningful and authentic engagement with communities, because we have really historically seen too many instances in which community is not at the table, in which decisions are being made for community as opposed to with community.
Indeed. Those are extremely important points. I kind of see like that you wanted to say something, Sandra, did you?
Yeah, I just wanted to build on that and give a really important case example of where that has worked, I think, exceptionally well. So much about this COVID pandemic brings back lessons learned from the HIV epidemic and how we responded during that period of time. And as I have reflected on that, one big takeaway has been that when we finally got the attention of the federal government to the nature of the HIV epidemic, and the Ryan White Act was passed, the Ryan White Act required that regions came together and that people who were living with HIV were at the table, and decisions about how to allocate Ryan White dollars in a region like the San Francisco Bay Area, I think as a model in so many different ways, whether it was through the needle exchange program or the like, was really built well, largely because we had people living with AIDS who were losing their loved ones and their friends and their colleagues at enormous rates at the table, actually designing the community-based care delivery system that we built and sustained over a long period of time. And so Dr. Gracia's point that we should never try to solve any public health problem without having the communities who are living that experience every day at the table, guiding us and giving us critical input in consumer design and what works and who's going to use what services and how do we deliver them and where do we deliver them and how do we message them. So I think there's a lot to be learned from the things that went well in the HIV epidemic in this country. And I would argue that the consumer activism, the gay community, it's, you know, Dr. Fauci talks about this all the time, about how much it pushed to get drugs onto the market to deal with HIV. But mostly I take away from that the importance of having the very communities that you're trying to work with, aggregating the data, understanding the data, collecting the data, being informed about how to use that data and that information, We did a lot of community-based research in the early days of the HIV epidemic. And I think those are big takeaways as we think about rebuilding our public health infrastructure in this country, and how important it is not to fragment public health from the delivery of care. And as I've seen in California, and really kudos to the entire University of California system, probably the best example of the academy working in conjunction with local health departments and communities to respond to this pandemic. And I think that merger of really understanding how the delivery system and our public health system need to be fully integrated, how data needs to be shared, and how important the consumer and patient is in that conversation is really one of the take-home lessons we should have coming out of COVID-19.
I agree. I remember when we were at San Francisco General Hospital and working out of Ward 86 and seeing the patients and certainly inspirational moments that I had at the intersection of community, academics, sort of practitioners, all working together, not only locally, but also internationally as we went to other places through the support of organizations like San Francisco AIDS Foundation to share the lessons learned. So a strong solidarity. And it also makes me think of other areas, other important areas. One of those is access to care. Certainly another extremely important piece of this complex puzzle. As Sandro said, in which I agree with fully, and reminds me of what another friend of mine, Larry Cohen, used to say, you don't solve complex issues with simple solutions. You solve it through comprehensive ways. And one of these issues is the access to care challenge. We are perhaps the only developed country that does not have a universal health system. California has been grappling with that a lot. We've got lots of movements, and there's challenges with regards to how we do it. Really not. And there's some people who are incrementalists, and some people who want to just move in that direction. Perhaps this is more about strategy and how we accomplish something that many of us share as an ultimate goal. So, Sandra, you recently have been doing some work in that area, I know, and you continually have been doing work in that area, I should say, both on the foundation level as well as in the state. You want to just kick it off with a few issues, and perhaps we can be joined by Sandra and Nadine on this topic?
Sure. Well, I would put a fine point on the notion that California, in many ways, has been the lead train and the engine to universal coverage for the country. It very aggressively, legislature working with the Republican governor at the time, implemented essentially all the components of the ACA and then some. Governor Newsom recently added individuals who don't have legal documentation up to the age of 26 in state-owned Medicaid program. I think, and by the way, just a moment to reflect that, one of the things I think we need to do as a country, I've been struck that, the Congress tried 37 times to repeal the ACA with no comprehensive mechanism or program in lieu of it. Some people would argue largely because it was referred to as Obamacare. And I do think one of our challenges in this country is to get at least consensus across all parties, rural, urban, suburban. And I'm seeing this a bit in COVID and the stories about COVID. Who believed it was lethal and who didn't, and who believes in wearing a mask and who doesn't. And I think the biggest challenge we have as a country is to come to understand, we talk about universal coverage. Is it a socialism? Is it Medicare for all? If we could just agree across all of our people, urban, rural, red, blue, whatever, that everybody wants the best for their loved ones. They want them to be well. They don't want them to suffer from mental illness. They don't want them to be addicted to opioids. They don't want them to die in a respirator due to COVID-19. And so I think we have to get out of this just political tug of war around the details of a program. The ACA is good. It did many, many things in terms of enrolling and expanding Medicaid. In particular, California is a very strong individual exchange. I'll disclose I'm on that board. Peter Lee does a great job at that. But I think as a country, we need to have a frame that we want the best care at a price that we can all afford for our loved ones. That would be an enormous step forward for this country. And I think we get lost in the partisan, profound partisan, it's bad, it's not bad. I mean, you would think that the only thing the ACA did was prevent people from being discriminated due to pre-existing conditions. It has so many other important provisions that don't get talked about in the body politic. So yes, California is on the train. We will continue to be on the train, aggressive with regard to our individual marketplace, aggressively trying to enroll people and sustain their enrollment where appropriate on Medi-Cal, making sure that program is a comprehensive program and that people actually can access the specialty care that they need, which we know by data it currently doesn't. So the Healthcare for All Commission, as you know, came out of a desire to bill that was introduced and was tabled by the legislature that would have called for, quote, a single payer, one way to pay for X, fill in the blank. I think we've learned a lot about our delivery system, which is you get the fragmentation we pay for. And so I think what the opportunity is in this conversation is really to understand how all of these public programs can better align and synergize. 40,000 people come in and out of Medi-Cal and Covered California every month. Incredible administrative churn. And when we talk about it as administrative churn for the average individual, it's an incredible nightmare. I was on Covered California. I had to take care of a loved one who was sick. That made me go into Medi-Cal, and a month later I was eligible for Medicare. Literally, in 2 months, 3 public programs, all aimed at trying to do the same thing. And so I think we have enormous opportunity in California to synergize our public programs to the extent that we can, and to align the values of what we're actually paying providers to give us as outcomes. And if nothing else, we saw through COVID-19 that fee-for-service is not the way either to provide good outcomes or to sustain delivery systems and primary care clinics and primary care practices all across the state. We're not done in California. We have a great governor who believes in this. We have a legislature who believes in it. We passed the individual mandate in the state when it got repealed. But I think there's a conversation that we need to take out of a partisan lens so this country as a whole understands that you need everybody in the tent. And you need everybody in the tent because that means you and your loved one and your children and your grandchild and your elderly parent with dementia. And until we recognize and can change that conversation, we're going to be in this body politic of, Obamacare is the blue version, and, it's going to be socialism when we do a public option, which I think really distracts us as a country. Look at countries that have universal coverage. Those countries have done much better by containing COVID-19 than we have as a country, notwithstanding the federal leadership that you referenced, Michael, in your earlier remarks. So I'll stop there.
Indeed, lots to chew on there with the leadership, the desire to want to have something that we all want for our own loved ones, and getting all on the same page. On this last point, Nadine, you're in DC, okay? Getting all on the same page. You've worked for the Office of Minority Health. right? Leadership offices has some input here. From your experience, how do we do that? How do we get on the same page? How do we move forward on this issue?
Well, I think touching back to a point that Dr. Hernandez was raising was how we ensure that this should not be a partisan issue. And I would say that similarly as well of health equity, right? That health equity should also not be a partisan issue. That is really a foundational, should be a foundational tenet of our society and our nation. That is a vision that we have, that health equity and prevention would be foundational to policymaking at all levels of society, from the federal to state and local levels of society and in the policy making process. And as Dr. Hernandez said, if anything, the COVID-19 pandemic is demonstrating that. And I think that, sometimes the language certainly will differ. Who started an initiative differs, but I think if we need to come to some core values of, do we believe in fairness? Do we believe in justice? Do we see the disproportionate impact that this is having on specific communities and how that is not fairness and injustice embodied? Then what are the ways in which we can actually work to address those inequities? When we look at issues like, yes, we should certainly be working to address it and guaranteeing that everyone has access to health coverage. And in the midst of a pandemic, should not be considering dismantling the Affordable Care Act, which is so vital for millions of Americans. And we can look at Medicaid expansion, for example, where Black and Latino residents disproportionately live in the states that haven't expanded Medicaid, and yet we know the health and economic benefits at the federal level as well as at the state level and in local communities with regards to access to Medicaid. And so we do indeed have to move from that. And I think we spend a great deal of time in working to address what are some of the key ways in which, whether it's on issues of health coverage, but also in prevention, that we can focus on this in a way that is not partisan. There is much that is at risk. Within the Affordable Care Act, there's also the Prevention and Public Health Fund, where that is mandatory funding for prevention and public health, and yet it is seen $11 billion, more than $11 billion cut since the fund was enacted, and that is at risk. And so when we talk about the opportunity to truly advance equity, it's being able to come together on issues that we recognize, whether it's public health emergencies or issues like the opioid crisis and more broadly substance misuse, where we've seen how it has changed with regards to thinking about this crisis. But we knew that there were inequities when it depended on communities that were impacted in past epidemics. We have to really understand that there is not only, importantly, the moral argument, there's an economic argument as well to be made for really setting aside the partisanship and actually addressing the fundamental conditions that will actually help people be healthy and create health and well-being in all communities.
Thank you so much, Nadine. Sandro, you have famously been quoted frequently, including by me, as a person who talks about threading the needle. How would you thread the needle in this case?
Yeah, I think, Dr. Hernandez's, Dr. Gracia's last comments, I would bring them together by talking about our need as a society to embrace health as a public good. We have long privileged a notion, a false notion, of health as an individual commodity, something that we can buy and sell. And that notion has resulted in health haves and health have-nots. And those who are health haves achieve far less than they could if we ultimately saw health as a public good. By seeing health as a public good, that means that you see health as something that we collectively invest in that benefits us all. And a lot of things then fall from that. A lot of the policy implications that Dr. Gracia just mentioned, a lot of ways in which we could structure the healthcare system that Dr. Hernandez was mentioning. And one of the things I've enjoyed about this conversation is that we have been very fluid about the line between what is typically sort of health care and the line what is typically sort of social determinants of health. And that line has been really blurred in this conversation. And I actually think that's a real positive, because fundamentally what we're talking about are different dimensions of what generates health. They're all different dimensions of what generate health. Having stable housing generates health. Having the assets to be able to afford a livable wage able to afford parks for exercise and nutritious food generates health. Having a healthcare system to screen you for disease and to treat you when you're sick also generates health. And all of those, I think, need to come together. And for them to come together, you need to see health as a public good, something that we are all invested in, something that we all care about. And I was struck by Dr. Hernandez made the point about, we care about health for our families. And I've actually used that line. Usually I'm a bit more perhaps craven about it, where I say it's about health for our children, because people seem to respond to that and say, we all want health for our children. And we are simply not going to achieve that. We are underperforming on health unless we think of ways in which we collectively recognize our investment in health. And just one last thing on this. If a global pandemic is not a moment that teaches us that, I don't know what is. If a global pandemic is not a moment that teaches us that, Michael, my health depends on your health. I may care about you because I'm a compassionate human being, but even leaving that aside, in a moment of pandemic should teach us that I should care about you because actually, if you're sick, I might get sick. So the pandemic should be a clarifying moment for all of us that we need to invest in our collective health and invest in health as a shared public good.
Completely agree. A teachable moment, Dr. Central.
One would hope so. Whether we learn or not is the question.
Well, speaking of moments, the moment has come to say final words for this panel as we transition to our next phase. And so, Sandra, since you last said a couple of words, why don't you go first in terms of helping us to sort of just, what final words would you like to leave the audience with that would help us to bring us back, help ground us in this topic of social justice and health equity, and respond to Dr. Drake's call to action in the Rick Brown vision?
Yeah, look, notwithstanding what we're seeing in COVID-19 in real time, it is a very important moment in history. And I actually think that these confluence of discussions about race and racism in our country, this concept of community and caring for one another, what Sandra was referring to a moment ago, which is the notion of public good. And I think a self-reflection on the delivery system, which we have all worked in, really reflecting on academia. I think it's really important to note, and this is a conference being put on by the university. Dr. Drake gave us some opening inspiring remarks. Academia needs to do a self-reflection at this moment as well. A lot of the reasons that we have a vertical approach, a disease-only approach, is a lot about the way that we operate in the academic world. We're going to get into a conversation with students, and I think what the big takeaway message is that these are interlapping, interdisciplinary policies and programs, and that what we really need to be able to do is look at how all of those pieces fit together. And I think COVID-19 is a moment in time overlapping with the racial reckoning that we're having in this country, and also the movement towards activism. Mm-hmm. People are waiting in line for hours to vote in Georgia, right? Now maybe they shouldn't be waiting in line, but what it says is that people recognize that their voice matters. And I think that is the other very hopeful piece about this. I've often heard about the Latinx community and we're a sleeping giant. And yet I've seen the Latino organizations all across the state and the country mobilizing the next generation of leadership. So I'm delighted that we're moving into a conversation with students. We're really, talking about, applied research and not waiting for the definitive answer to try a solution in a community. I think, having held public roles and private roles, really appreciating our public sector for the challenges that they are facing, and recognizing that we need the next generation of people to step into those roles for us to take this disruptive moment, a moment of reckoning, and really moving us in a meaningful way towards health equity.
Thank you. Nadine.
I support what Dr. Hernandez articulated and would say, let this be a punctuation point in our history, a punctuation point that really moves us into a next chapter of advancing and on our journey into equity. I would say that this pandemic, many have talked about multiple pandemics, whether it's the pandemic of structural racism or seeing the economic inequality that exists, to a whole host of other pandemics, and that should be certainly a catalyst for accelerated action. There's a need for leadership in all of this, and I think that sometimes it can also create stagnation in thinking that the problem is so large that it may be insurmountable, and yet we really cannot turn back. We cannot turn back to how these inequities have long existed in our nation, but we also recognize that we're going to need to step outside of our comfort zone of working with where we may have traditionally worked to working with new partners, and especially those who may have not had a voice or have been disenfranchised from actually being able to express the needs of their communities, to ensuring that we create opportunity for everyone. I think in particular for the students that are listening, that often I hear the what can we do as students, and we only need to look back at so many of the movements that existed in our country, such as the civil rights movement and the role that students played with regards to really driving change. We can see that now too. And so I think I agree with Ninez that confluence of racial injustice with this pandemic should certainly, I think, mobilize us to even more greater concerted action in holding leadership accountable, in allowing, for example, in this pandemic, public health and science to lead as we address the needs for the pandemic itself and our recovery from it, so that we truly can reach that just and equitable nation that is really within our grasp and within our reach if we are committed and if we sustain our efforts.
Thank you. Sandro.
Yeah, thank you. The only thing I will say, I think Dr. Gracia and Hernandez said it all really well. Look, this is a terrible moment. It is, lives are being lost unnecessarily. The economy is being upended unnecessarily. I think the long-term consequences of the economic downturn are going to even outweigh the consequences that we're seeing in COVID right now. This is horrible. Like, it's a really sad moment. And the question is, how does one even try to redeem a moment like this? And I think if we do not emerge from this moment with a greater clarity about what it's going to take to make us healthy in the future, and that is through systematic investment in the structures that make us healthy, be they housing, be they assets, be they reducing stressors, be they livable wages, be they gender equity, be they restructuring the healthcare system. If we do not emerge from this moment with a commitment to do that, the moment will truly, truly be a loss for all of us. So you mentioned earlier, Michael, I'm a pragmatist. I am a pragmatist. I like to be a pragmatic optimist. I do think there's optimism, but the optimism doesn't just happen passively. It has to happen with people of good conscience, like everybody on this call, demanding that we move forward, we learn from this moment, and that we transform our world for the better. So thank you for hosting this conversation and allowing us to put that agenda out there.
Thank you, Sandro. I'm so deeply grateful for the leadership, insights, and inspiration that you, Dr. Hernandez, Dr. Gracia, Dr. Galeo have just shared. I'm thankful for the audience participation, including their questions and comments. I also thank my colleagues I've worked with on this panel, along with the numerous other advocates and collaborators whose vision and passion help promote health equity locally, nationally, and globally. As we promote the health of populations, we keep in mind that every person matters, and every one of us can have a lasting impact on improving our world. I thank you all, and we will now take a 7-minute break. We will be back at 11:40 for our next panel. Thank you.
That was a terrific panel. Thank you.
Okay?
Yes.
Good.
Are we live for everyone, or is it just the panelists? Oh, we're live. Okay.
Hello, everyone. Welcome back for the second panel of our symposium today. I want to start by thanking Ninez, Ponce, and the entire staff of the Center for Health Policy Research for putting together this incredibly important symposium, and to Dr. Michael Rodriguez and our excellent star-studded first panel for an outstanding discussion to get this going. Really remarkable contributions. We are now going to move into the panel on repairing a fractured healthcare system to fulfill the promise of health equity. As President Drake began his comments when we started this morning, and as Dr. Michael Rodriguez in the first panel discussed, there are profound things going on in our society that really drive important questions about the status of our healthcare system. Three that stand out in the social economic forces at play right now are, of course, COVID, the pandemic, which we've had much discussion about, the associated economic turmoil, and all the appropriate concentration on the social movements on racial justice led by Black Lives Matter and other kinds of groups and organizations. And they've really brought to the surface, has been commented or accentuated or placed a spotlight on enormous concerns, not just about health in general, which is the fundamental issue, but about the healthcare system itself within that context. Just a few of the things that have been made transparently obvious right now is that the backbone of the American healthcare financing system, the employer-sponsored insurance system, has been really shown to be quite fragile and unstable. And of course, it's also pretty much a backbone of the Affordable Care Act. We see now the states under tremendous pressure and their state Medicaid programs under tremendous pressure as people have shifted into that program, having lost other kinds of coverage. They're facing their own financial crises. And we see in stark reality the gaps in coverage that exist in the non-expansion states because there's no place for lower income people to go who are outside of the existing Medicaid program. We see profoundly variations across racial lines, ethnicities, and social economic status in financial protections, in access to care, in quality, even quality of the treatments provided, with distinctly unequal life and death consequences. We have three outstanding panelists to discuss these issues. I want to go a little bit into their biographies, not a great deal. I don't want to spend all my time on what would be a very lengthy discussion, and you can go to their bios that have been provided by the symposium. But I do want to give you all a context for the perspectives that each of these panelists is going to be bringing. We're going to start with Dr. Lisa Simpson, who for nearly the last decade has been the president and CEO of Academy Health, the preeminent professional society in health services, research, and health policy. She knows clinical practice firsthand as a pediatrician, and with an MPH from the University of Hawaii and postdoctoral fellowship in health services research and health policy at UCSF, became a national leader in health policy and the translation of research into policy and practice, including as deputy director of the Agency for Healthcare Research and Quality. In her various roles, she has seen the healthcare system and health policy about it pretty much from soup to nuts, from the local level to the national level. And she is not surprisingly an elected member of the National Academy of Medicine. Next, we're going to have Lan-Hee Chen, who is the David and Diane Steffi Fellow in American Public Policy Studies and the Director of Domestic Policy Studies at the Hoover Institution at Stanford University. He has a PhD in political science from Harvard University and a JD from its law school. He has had wide-ranging roles in a number of fields in academia, on think tanks, nonprofits, campaigns, and government. They include as the policy director of the Romney-Ryan presidential campaign in 2012, as the policy director for Governor Romney's 2008 presidential run, and as a senior advisor for the National Republican Senatorial Committee. He's been a member of the Social Security Advisory Board, and he served as a senior official in the U.S. Department of Health and Human Services during the George W. Bush administration. And third, we have Anthony Wright, with long experience as a consumer advocate and community organizer in both New Jersey and California. Since 2002, he has served as the executive director of Health Access California, a statewide healthcare consumer advocacy coalition, in addition to leading campaigns for national and state consumer protections, investments, and safety net programs, promoting prevention, and generally advocating for comprehensive healthcare reform, either through requirements on employers or all the way through the single payer plans, He led efforts from California to enact the Affordable Care Act, along with the state's own initiatives to implement the new law and strengthen it. As with Sandra Hernandez from the first panel, he is currently a member of the Healthy California for All Commission, launched by Governor Gavin Newsom and the legislature at the end of 2019. In the advance of our coming together today, I had posed 3 questions to the panelists to get the conversation going, and an invitation to them to pursue those questions in any way they think would be most effective for their opening comments. I don't want to take away from Dr. Sandra Galea's important point that we really shouldn't be separating health and healthcare, something I strongly believe in that integration. But we do have to ask the question, do you think the deficiencies or dysfunctions in the US healthcare financing delivery system itself have played a significant role in the health problems that emerged from the pandemic, especially the stark disparities along racial and ethnic lines, or are most of the causes more upstream beyond the medical system itself? Number 2, if dysfunctions in the healthcare system are playing a major role, what would you identify as the most important deficiencies? What has been revealed to cause the most harm, inequitable access, care, health, and mortality? And third, following from that, what policy interventions, getting to the real practical matter, what policy interventions at the federal, state, or local level would you identify as most effective or promising for fixing the system, improving health, and most importantly, promoting equity? In a sense, what do we do? How do we make some progress on these fronts? How do we, when we think about the Center for Health Policy Research, to recognize it's really in many ways the Center for Health Policy per se in trying to advance those issues. To the audience, let me say, as you have questions that come to mind, please use the Q&A button at the bottom of your screen to pose those questions, and we will try to get to some of those, as many as we can, later in the session. So with that, and without further ado, let's start with Lisa Simpson. Lisa.
Great. Thank you so much, Mark. And it really is an honor to be here at the 2020 E. Richard Brown Symposium. For anyone who knew Rick, his dedication to using data to inform policy reminds us all of the power of data and facts to change the conversation, as Dr. Galeo said earlier in an amazing panel discussion, but also to use that data to spur health reform and ultimately health improvement. And this use of data, this use of evidence is really core to Academy Health's mission, which is to improve health and healthcare for all by advancing evidence to inform, as Mark said, policy and practice. I also want to thank Dr. Ponce for inviting me to join you here today. I personally am delighted that she is such an active member of the Academy Health community, and that her work and the CHIS that Rick Brown launched were recognized in 2019 with an HSR Impact Award, a high honor in our field. Now, as other speakers and Dr. Michael Drake have eloquently described, there are many aspects to our fractured and I would say failed health system that need to be addressed going forward. And it's a lot to take on. And so I want to focus my opening comments, both in response to Mark and some thoughts, on just some of those dimensions, and particularly those that are accentuated by the complex interplay of state and local policies. And then I will close my initial remarks by just suggesting 3 areas to focus on as we build an equitable and effective, and to the cost question that Mark raised, sustainable health system. And I look forward very much to my conversation with Mark and the co-panelists. So turning from that intro, I want to focus on 4 aspects of our fractured and failed health system. The first has been very much the topic of the prior panel, and that is the devastating impact of the pandemic on communities of color and low-wage workers that has made the inequality that has always existed in America evident to even the most willful blind observer. America can no longer look away, and neither can our healthcare system. And we know that these inequalities are not just the unfortunate byproducts of a society. They are the natural consequences of decades of policy choices and private actions, many driven by overt and systemic racism. And this affects our health care system and our health policy just as much. Second, the pandemic has forced us to think about our health workforce, its composition, its skills, its resilience, and sadly, its basic safety that I thought unimaginable just a year ago. For example, I never thought, having grown up overseas and spent a little time in low and middle income countries, that I would see nurses in this country using garbage bags to protect themselves due to a lack of PPE. And we cannot ignore that this direct threat to the workforce's safety comes on top of a growing epidemic of burnout among frontline clinicians that has left them emotionally exhausted. And to the earlier point about this is a webinar hosted by UCLA and the center, you know, I have a niece in medical school. I have a daughter who is majoring undergrad in public health. So we have to think about the professional workforce both today and tomorrow. And here again, with that workforce, the burden falls disproportionately on lower wage workers in healthcare settings and on those professionals who are professionals of color due to the ubiquitous nature of structural racism in healthcare and academic settings themselves. The third aspect I want to underscore is the decades-long financial starvation of our public health infrastructure nationally and at the state and local levels that has left health departments and their partners struggling to respond in a timely and robust manner. To compound this, we have seen more recently the actual, not just the historical devaluing of public health agencies and the dedicated professionals who work in them, but we have seen outright targeting of public health leaders who speak up and speak out, who are trying to apply science to protect their communities. And the fourth aspect of the current world we live in that affects healthcare is that we have seen an almost complete failure of our health data ecosystem and the steady decline in data quality produced by the government. And both of those are itself threats to our information-based economy. So how can we make progress, as Rick knew, without trustworthy data? We must address that aspect of the healthcare system and the broader health system as we think forward. Now, these four challenges that I've chosen to highlight do not exist in a vacuum. They have been reinforced, as I mentioned earlier, by the critical interplay of federal, state, and local policies. Now, the failure of federal leadership, despite valiant and sustained efforts by scientists in federal agencies, must be called out, as it was in the recent New England Journal of Medicine editorial, one that was unprecedented in its 208-year history. The extreme devolution to states and localities that we are seeing in a time of crisis has resulted in significant variation in what I will call today the 3 Ds of the dimensions of the pandemic, and that is the degree of disruption, the disproportionate impact, and the decision-making capacity, and how it varies across states and localities. So to say a little bit more about each of these 3 Ds, first, the disruption in healthcare is happening at different times and in different ways, depending on both pre-existing market and population characteristics. And we've talked a bit more about the population and community characteristics, but also the healthcare marketplace and its characteristics have either helped communities and health systems respond or actually contributed to their failure and their struggles during this response to the pandemic. Each community and each state and locality is at different stages of the transformation towards, say, a move to value. As Dr. Hernandez mentioned, our fee-for-service system is not serving health improvement. It is not serving many communities. We need to move more towards population health and equity, as has been described. But policymakers at each of those 3 levels are managing disruption at different stages. And I think we have an opportunity to learn across states and across communities how to effectively do this. And we've talked a lot earlier at the panel prior to this one spoke about the need to act and not just learn, but it's the two together. We must act now with the knowledge we have, as Dr. Galeo said, and invest in the learning along the way. And the third D is, of course, the disproportionate impact. We have talked a lot today about the impact depending on the socioeconomic and racial and ethnic makeups of communities. But because of this disproportionate impact, another dimension of this is that these are also communities that disproportionately rely on Medicaid policy and Medicaid services, not just for low-income populations and low-wage workers and disproportionately persons of color, but also the role of Medicaid policy in settings that have been so hard hit by the pandemic, like long-term care. But historically, our Medicaid agencies in some have been seen too often as the insurance agencies and not key components of a state strategy to improve health. And having worked in a state health department early in my career, I know that there's also a highly variable track record of effective collaboration with state health departments. And I think today we have an opportunity to break down these silos and codify policies and processes that were launched in response to this pandemic that will sustain Medicaid and state health department collaborations to move effectively and more quickly to meet the needs of their populations. So for states the third D that I want to mention is the need for states to have the capacity for informed decision-making. And how do states have access to that data, to that evidence? California is rich compared to some states in its data and evidence resources. Centers like Dr. Ponce's and other at the various UC system and other organizations in the community that can participate in the state policymaking progress, but not all states are that fortunate. And so like many other aspects of state policymaking, that capacity to make informed decision-making is supported by networks of state policymakers, and Academy Health is pleased to be able to host 3 of those networks. And so those are aspects that I think we want to talk some more about. So 3 possible strategies going forward. I know others are going to bring others to bear, but I want to just highlight 3 in closing. One is, in recent years, we have talked increasingly on the national and community stages of using an equity lens to policy and system actions. I think we have to go beyond that. We have the opportunity to design for equity up front. We have been disrupted. Now is the time to rethink all the basic premises, and we must tackle structural racism in all of its forms, which will be daunting and even more disruptive, but we must commit ourselves to that goal. And as I said earlier, we must learn from our actions, because while our field of health services research has spent decades documenting and trying to understand the causes of unequal outcomes in health, we need to generate more evidence about the most effective ways to address those inequalities in different contexts. So moving forward, how do we spur and reward innovation at scale that we have not seen before? Here, I think we do need federal leadership, and we need private sector engagement. We have declared moonshots in the past. We must have the same level of investment and attention from the public and private sector to design for equity upfront and think boldly. It can be done. Just a year ago, none of us would have thought that health systems could have pivoted to telehealth the way we do. So what was inconceivable pre-pandemic is now possible. What else can we accomplish? And part of that moonshot is creating, supporting, and rewarding a diverse workforce in healthcare and public health. And I hope we get a chance to talk more about that. The second aspect of our strategy beyond designing for equity is dismantling the current incentives. As we know, and has been said, our system has been perfectly designed to achieve the outcomes it gets. And the incentives our system has are part of that. And in fact can penalize those providers who serve the neediest. So for example, can we think creatively about incentives, such as the incentive of federal policy to state Medicaid agencies, deciding what level of activities are at what level of match? This may sound like arcane policy conversation, but depending on how well matched those state investments are, can drive state action. Could one incentivize state Medicaid agencies to achieve equitable health systems and health care? That would be powerful. And then finally, we must move beyond the starvation of public health. Dr. Garcia and the Trust for America's Health report lays out a wonderful roadmap, but we can no longer starve our public health agencies. We must make up for years, and in fact, over a century of disinvestment. So in closing, I just want to say these are trying times to be an optimist. I like Sandra's pragmatic optimist. And I believe our field of health services research, with its applied, multidisciplinary, and evidence-centered approach to problem solving is and must be part of the strategy to fix our fractured health system. And so my last comment is in my email. If you've ever received an email from me, you'll see the signature block says, if not us, then who? If not now, when? Thank you, Mark.
Thank you very much, Lisa. Well, you covered a lot of territory there, so many issues that each one of which could be a symposium in many ways in and of itself. The one thing I want to underscore is in the opening part of your comments, you identified things that are both so obvious to everybody now because of the pandemic, but some things that aren't, that probably are well known in this group, but not widely known. And the other important thing is how much policy has already been driving these things. This didn't happen by accident. This is the result of policy choices, which also means that policy choices can make a big difference. As we move forward, we'll have more conversation about that. Thank you. Next up, Lonnie Chen, please join the conversation.
Well, thank you, Mark, and it's good to be with Lisa and Anthony here this afternoon, I guess now we're in. I'm going to keep my remarks relatively brief so we can get into the conversation. I think we are at a fundamental point of discussion when we think about our healthcare system. And that discussion will center around the issue of whether, in fact, our healthcare system is so completely broken that it needs to be completely reworked from the ground up, or whether, in fact, we need to consider the positive elements of our system and build on those. I think the COVID-19 pandemic has made abundantly clear the fact that our system does not work well for all involved. It does not work well for those who have fallen behind. It does not work well for healthcare workers in many cases. It doesn't work well for those who experience disparate outcomes, in part because of some of the systemic issues that we face in our country, but also more broadly because, as Lisa alluded to, some of the questions on system design that have been a byproduct of policy, most of which has been undertaken with eyes wide open, if we look at it quite frankly. I'm of the view that there is much in our healthcare system to redeem, and there's much in our healthcare system to improve upon. And for those reasons, at this point, a complete reconstruction is neither desirable nor fundamentally will achieve the goals that we want it to. You know, if you look back at American history, our system has been built on decades of decisions, some of which, for example, have bolstered the employer-sponsored health insurance system, which has worked fairly well for 160 million Americans, as well as public programs, which are vitally important, Medicaid, Medicare, the VA, et cetera. And so the question becomes, how do you blend these systems together? How do you make them work better? And I would submit that really for policymakers, the practical next questions, whether this election goes for a second term of President Trump, or if Vice President Joe Biden is elected, I think going forward, the question is, how do you build on what's working and how do you repair or get rid of what's not? And I think fundamentally that question, one about repairing and trying to work with the system versus trying to completely change and rework what we have, I think that's going to be the fundamental question that animates health policy in a policy sense, but also I think in a political sense going forward. And it's a very real debate. We look around the world at systems that seem to perform better and we ask why ours can't do the same. And I think there are things to be learned. I think that's one thing that policymakers in America don't do often enough, which is to think about how other systems around the world work and in some ways work better, and adopt elements of those systems that we might be able to learn from and grow from and make our system better so that it better serves everybody, not just those who have certain kinds of health insurance or those who have access to health care in certain ways. I think there are a few items, public policy items, that are areas of focus that I would hope policymakers turn their attention to over these next several years. The first and most obvious problem I think our system has is we continue to have a system where cost is prohibitive for too many. And we can think about costs in a variety of different ways. We can also think about our healthcare system and the amount we spend overall, but clearly there are significant inefficiencies here. And questions of how to address rising cost, rising premium pressure that many working families face, as well as more broadly, as we continue to have a very innovative system, and those innovative cures and innovative interventions that we know about in our healthcare system come on market, many of those are inaccessible to too many. So how do we increase accessibility while also thinking about issues of cost that continue to predominate our system? And look, in a lot of ways, I think if we went back and redesigned the system, we would want to think carefully about a system that really removes the end consumer of healthcare from a great understanding about, first of all, what they're consuming, second of all, how much they're consuming, and third of all, what they're consuming and how much it costs. I think there's a great degree of a lack of knowledge, and I think part of that has grown up because of our system and the way it is, and part of it has grown up with other policy decisions that have been made over time by both Republican and Democratic, conservative and liberal policymakers. And so I think it's important to think about how we address these issues of cost. I should have said before I get into these 4 areas of focus that I don't actually think there's a lot of disagreement between people of different political stripes about the need to address these concerns. I think there will be disagreement about how we do it. But I think the notion that these are issues that have to be addressed to improve our system, I think, is relatively uncontroversial. The second point I would make is related to the first, which is we don't have nearly enough engagement amongst those who do have access to the healthcare system in a very fulsome way. And I think that goes again to the problems that we have around a lack of transparency of information, around quality and cost, but also more broadly, a lack of understanding around how the healthcare financing system works. I think most Americans feel very fortunate to have coverage. They use that coverage and they exercise it. They go to the doctor's office or they go get a vaccine. And that really may signal the end. In some cases, though, unfortunately, too many still don't have a great sense of why they're getting billed what they're getting billed, why they're getting sent something that they believe they shouldn't have to pay for, but do. All of these kinds of questions around patient engagement, which are related to the first issue I raised, I think we have to get that right. I think we have to figure out how to get patients more engaged, but at the same time, how to ensure that they understand why it is they're getting bills for what they're getting bills for. And some of that rationalization doesn't happen in our system now. And I think, quite frankly, it needs to happen better. Third, I think we have a huge problem around consolidation in our healthcare system. And that consolidation has led to rising costs. It's led to declining choice. And in many markets, it has chased out providers who would otherwise probably want to provide care in those markets. And we see a particular challenge in rural areas in America, which I know is not in vogue to talk about, but I do think is a serious problem. When you have rural healthcare, rural communities where there's only one big acute care provider, or only maybe a few people who provide specialty care, I think that is a big challenge. And the consolidation that's happened over time has happened in part because of the incentives in place, the economic incentives in place, but also because of the way in which we haven't had the first 2 things. We haven't had an effort to engage costs directly, and we haven't had an effort to engage patients directly. So a lot of that consolidation, previously the view was, well, as long as that consolidation isn't happening too much in any given geographic area, that's fine. And then we said, well, as long as the consolidation isn't horizontal in nature, we're fine. Well, what we're realizing now is that system consolidation is driving a significant amount of cost, and policymakers have to get serious about using the tools at their disposal, antitrust tools, tools to examine whether consolidations are good for consumers in the healthcare system. But more broadly, policymakers need to be given even more tools, I'd argue, to address system consolidation and to fight really what I think is monopolistic behavior, anti-competitive behavior in many cases, behaviors that do drive up cost and make it more difficult for people to access the healthcare system in an affordable way. And finally, a word about the Affordable Care Act. I think that there are elements of the Affordable Care Act that have clearly worked well and need to be bolstered. And then I think we need to have a discussion about those that haven't worked as well and figure out how, in fact, we make those elements work better for our healthcare system, not to work better for the Affordable Care Act per se, but to work better for the healthcare system. How we have elements, for example, that make care and access easier for those who are working multiple jobs. I think about something called the family glitch, which all these years later still hasn't been addressed. It's a very basic problem. And it's a basic problem that impacts hundreds of thousands, if not millions, of American families. And so I think addressing that, figuring out, for example, how we can continue to ensure that those who have access to Medicaid in those states that have expanded Medicaid get access to that program, how those who don't have access in states that haven't expanded Medicaid, how we figure out coverage. In some cases, a Medicaid expansion will be appropriate. In other cases, there may be other policy interventions that have to happen. And you see states trying to do that now. And I think that will be the next frontier. I agree with Lisa in the sense that I think we have to get this balance between federal policymaking and state policymaking right over these next 4 years. And that will involve building on elements that we have come to rely on as a healthcare system, but also recognizing and acknowledging that the Affordable Care Act hasn't worked perfectly, and that there are ways in which the system as a whole can be improved, and that means in a certain degree changing elements of the Affordable Care Act to make them, in my view, work better. So I know that my view may be an alternative view amongst those who will speak today. I think it's an alternative view maybe amongst many of you who are listening and watching. But again, I think there is a consensus around these courses of these areas of challenge. And I think the course that we take, the way that we address them, that is where the policy debate ought to be. And I hope that we can have a real policy discussion going forward about the ways that we can address these problems, as opposed to talking past each other, which I think we've done now for far too long. The healthcare system and COVID-19 in particular have demonstrated that there are significant needs, and it's long past time now to address them. So with that, Mark, I'll turn it back to you.
Thank you very much, Wahi. We very explicitly wanted to have more than one lens on these issues and to have that kind of broad range of thinking about what the problems were and the possible solutions. So that is intended to be integrated into our discussion today. Two things stand out from me. Again, you cover a lot of things that I think a lot of the audience is very interested in. Two things stand out for me from your opening of your remarks. One is, and I write about this as do many other people, what you said is there's so much agreement about what's wrong in how the system's performing. The glitch is getting to where the disagreements are about the solutions and trying to figure out a pathway in which we can move forward on those. But I agree with you that there's pretty wide agreement on a number of areas that we'd all identify as being problematic. And the other is the incapacity of people in the United States to think about what can be drawn from the international experience. And in part of that is people on both the left and the right have this misconception that it's the United States and everybody else is exactly the same way in how they do things. The fact of the matter is every other country has its own particular version of a system that has historical and institutional roots. The one thing that does separate the United States is the fact that we do not have any kind of universal coverage commitment and system that gets more or less there. But the instruments for doing it are wide and varied and include significant roles, for instance, for private insurance in some countries, as opposed to government financing. But thank you very much, Ronnie, and we will now turn to Anthony Wright.
Thank you very much. I have had the pleasure of being on panels with Ronnie previously, and there's always a lot to respond to. But I want to start by just continuing in celebration of this continuing memorial to Professor Rick Brown, who was a giant in this field, who, and I think this symposium is just perfect in terms of both reflecting his deep desire for rigorous and important data to be put out there, but also for that to be really engaged with the policymaking process, that data is not something to go on a shelf or something to be debated in the ivory tower. It is to be explicitly used in the debate around policy in the field of ideas. And we, as Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition, we very much are consumers of the data of Rick Brown in the past and of the UCLA Center for Health Policy Research into the present. CalSim, just to take one of the products that Professor Ponce highlighted at the top, is something that has been invaluable in California's leadership to both implement and improve upon the Affordable Care Act, where California has, in fact, not just taken the steps to have the biggest drop of the uninsured rate of all 50 states, building on the good work that Dr. Brown and many of us in California have done, but also to improve upon it. And I think I just want to salute the center, both its founder and the center's work going forward with regard to that. Obviously the challenge of COVID-19, the pandemic, the new clarion call on racial justice, the economic crisis, all of these crises that we're dealing with today are, have brought up and highlighted some key issues and things that we have, I think, knew, but I think have highlighted. And I want to highlight just a couple. One is just this very fundamental notion that we're all better off when everybody's in the system. I know that the language that we sometimes use, including the title of the symposium, is healthcare as a right, which I think, as one of our previous panelists talked about, is an individualistic notion, but it is a public good. That in fact, it is something where we are all better off when we're all better off. Our healthcare system is stronger when everybody is included. My health is improved when somebody else is getting treated and tested and included in the systems with regard to COVID-19. There's no time than in an epidemic and in a pandemic where that is more true. And so I think that underlies many of the debates that we've had with regard to unfortunate and unjust exclusions in our healthcare system. And in particular, we can talk about income, we can talk about other factors, but in particular, the one that continues to rile us up, certainly nationally, which is that of immigration status. It's not just that immigrants are an important part of our society, our culture, our economy, and should be fully included in our health system as well. It's that it improves the health system for everybody when all of these folks, including those folks who tend to be the essential workers that we rely on, are also getting that care and getting that treatment, and should not be excluded from the various systems of care that we have from Medicaid on. And I'm glad that in California we've made progress in that regard. I do think I am heartened by the fact that maybe for the first time, or certainly I don't think there's another time in modern history where more Americans have thought of healthcare as a system more than this moment. Thinking about the system of how many ventilators there are, how many PPE there are, what is the capacity of that system. And I think it's a fundamental sea change to think of healthcare as a system rather than as a commodity. Because as a commodity, it sometimes means that then we get into the realm of scarcity. And certainly there are issues of scarcity where if somebody is getting more, then that means somebody else is getting less. And that has actually been one of the sort of underlying fears of some of the debates against efforts to expand coverage. And I think maybe we are figuring out that, in fact, again, our system is stronger when everybody is included. And I hope that we can take that ethos moving forward with both at the federal level and as we have been trying to do at the state level, with increased subsidies in covered California, with increased efforts to get people covered, and that work. I do want to challenge the notion that our health system would be improved by mere continuing to base it on just the pure let the market decide. Let's just engage patients and consumers more naturally to be active consumers. Usually when people are engaged in the healthcare system, they're at their most vulnerable, even for the most well-off and the most financed of us. People who are dealing with our healthcare system usually have a lot of other things to be dealing with at the time, and then to have a full understanding of the financing or billing or comparative shopping or other is a very tough situation. In fact, I absolutely agree that there is a deep issue with consolidation. I think I agree with my panelists on that subject, and whether introducing greater antitrust tools or other elements to that effort. But and we've been actively working on that in the state legislature and nationally. I would say that actually in many parts of healthcare, there is a monopoly. When you're in the gurney in an ambulance, you're in a monopoly situation, and that's what has caused the surprise medical billing issues that we've seen, for example. And I think there's a lot of situations where people don't have a lot of choices, both given the lack of medical expertise, but also just the construct of the one hospital in the town or 5 other things. And I do think that then that requires a role for a government and for policy. And right now we have lots of system. I'm glad that the symposium has the word fragmented in it, because I do think that one of the critiques of our current system is just how fragmented it is, how disconnected it is. And I would say one thing that have come into stark relief is the difference between our public health system and how divorced that is from the healthcare delivery system, which is how different it is from our financing system, and how those do not align particularly well. We're doing all this testing and tracing and really almost apart from, in some cases, the health delivery system, in some cases, I think, and then with regard to the financing of it, I think it was interesting to many of us how in the middle of a pandemic, when we thought that maybe the issue would be an overwhelming of our healthcare system, what actually happened was the shelter-in-place orders meant fewer people going to the doctor, and that was creating revenue shortfalls for our providers. And that goes to some of these issues of incentives that, again, my fellow panelists have talked about. It's a strange system that requires people to come in order for these essential services to be paid. We don't pay firefighters per fire. We don't pay librarians per book checked out. And yet and I think it does question, how do we get away from a per patient or per procedure payment towards more global budgets that are focused on quality and equity and outcomes and those types of improvements. And so I think that's work that we need to do. And all of these issues, I think, are and all of these system changes that I think are essential, I think won't by themselves solve the issues of the pandemic or solve the sort of the deep-seated disparities that, again, we've been talking about all morning. But I think what they do is they provide the tools to address them. That if we don't have a systemic approach to addressing disparities and inequities, if we don't have some oversight over the industry, over doctors and hospitals and drug companies, then we're not even at square one about holding these parts of the industry accountable for those goals. We need to have those tools in place. We can't let just the market decide, because what we discovered in the pandemic is that something can change in the market and we're totally unprepared for what happens next. We had a system that was set up to deal with a specific set of situation in the world, and in the world, there was a change in that world, and we were not prepared for it. And that would have been different if we had a system that actually had not just, that had some, as its goals, not just profit, but public health, prevention, and the greater public good. And so that's, I think, the conversation that I'm looking forward to, and I hope that we can advance it not just at the state level, but frankly at the federal level. And that's why, the election is so important. People will be making decisions on everything from local county budgets through Proposition 15, which will provide funding that could go to public health officers if possible. They will be making decisions at the state level. And obviously a lot of this is in the context of the federal government. And, I think we had a senator, the chairman of the Judiciary Committee, saying that the ACA was on the ballot, and I do think it is. And so I do think that fundamental foundation and framework about whether we're going backwards or going forward is something that we're very much in the throes of right now, and looking forward to this discussion both today, the next few weeks, and after November.
Thank you very much, Anthony. I appreciate your underscoring the notion that came also up in this morning's panel about health and healthcare being a public good and what that means. And of course, we could even go to microeconomics to describe what a public good is and how that is different from a private good being delivered in a market setting. But the other thing you brought up that others haven't yet mentioned too much is the role of immigration in the United States and the immigration status of so many people in the country. And of course, even under the ACA, many immigrants are left out. And it does raise this tension between a public good and people left out, and what happens to the people left out, not only to them, but to the larger society who were affected by the fact that they're at the front lines, they're delivering services, and they're more at risk for instance, in this pandemic, getting infected and even dying. So that's one of the tensions. I want to turn to all three of you you've all raised a number of important issues. Everyone is focusing on the role of the pandemic. We know we have an election coming up. I don't want to go too further right now, but there is a moment. This is a moment, and we, as a political scientists, we often talk about these particular times. Sometimes they're critical junctures, to use the jargon, of an opportunity for a different kind of change, or at least a different kind of coming together. And we've had a whole range of ideas put on the table here across the political spectrum to some extent. So turning to all of you, how do we seize this moment, and what direction do you see it going? Let me, yeah, Anthony, you can either continue with that, or we can go back to Lisa to start this continuation. Lisa.
All right. Well, I would be remiss, Mark, if I didn't first remind folks that Academy Health is a nonpartisan, bipartisan organization. And so we do not take positions on candidates or specific issues. We do advocate. We have an advocacy and policy agenda, which you know, we could go into at another time. But I think this is a moment, as you said, Mark, it is an opportunity for America to make a choice. And while most of us, or so much of the media, is helping us focus on the national stage and obviously the presidential election, I want to go back to an essential point I think that I included, which is the role of states. And we are in California today with all of you. And so while there are fewer governorships up, I just think that I believe we're going to see a continued role for the state governments and a rebalancing, a continued sort of tweaking and balancing of federalism and what gets done at the state level versus federal. And so I really think that they're both important. The final point I'd make on the election is we have seen increasingly, and I think Dr. Gracia's report, Tifa's report, Trust for America's Health, is just one latest example of the policy community's responsibility to bring forward not just analyses that describe the problem. As you said, we can all agree on the facets of the problem, but that lay forth options for action. And again, and that is the starting point of the conversation, because even if there's a switch in the White House and or the Senate, it doesn't mean we're all going to, you know, hold hands and sing Kumbaya. There's a lot of negotiation and discussion and work that comes after that. So we need to be ready for those in the audience who are in the business of either getting their degrees or producing information for decision makers. These are critical moments to get your information in front of those decision makers, whether they be national, state, or local.
Thank you, Lisa. I didn't want to put the weight on the election. I wanted to put the weight on the pandemic and kind of all the issues that have grown out of that. The election's in there, but just driven by what has come to the surface for so many Americans due to the pandemic, how do we seize that opening, whatever transpires federally, locally, statewide in electoral returns?
Well, and I'd be interested in my colleagues' comments on this as well. I think it's a fundamental, it's allowed us to think differently because things have gotten so bad. We have accepted for far too long that this is the way it is, that we can't change, that it's going to be too complicated. And yes, it's complicated. But again, to this point and others, you know, if health systems can turn on a dime once federal policy supports it in terms of telemedicine and state licensing, et cetera, we can move quickly. And so I think we have to capitalize on that, that self-efficacy, that we can move. We know enough to act if we can align the policies and the structures to support and reward that action.
Okay. Lanhi, do you think this moment in time and what we've all learned from the pandemic, or what's been so apparent to so many people, is an opportunity to bridge differences or to find a common path forward on at least some of the instruments for improving what's fractured in the healthcare system?
I do think it's an opportunity. I certainly think that some of this is going to get driven by the decisions that policymakers make after the election is over. I mean, it's hard to envision a situation where the tone and tenor taken by whoever it is that gets elected won't affect kind of the pathway forward. There's no question, though, that if you look back over what's happened to this country over the last several months, what's happened to the world, you can't help but have a conversation about the kinds of changes that are needed in our healthcare system. And I think that goes to a number of different things. I think Lisa's discussion about state versus federal is very meaningful. I think there is a tremendous amount of play in the joints in our healthcare system that will happen at that intersection of what state governments are doing, what the federal government is permitting or not permitting, and how they work together a partner versus being in conflict, which I don't think yields good outcomes, whether you are dispositionally conservative or dispositionally progressive. I guess I would say that I'm cautiously optimistic that there will be a pathway forward for us to come to agreement on some issues, and I think the pandemic will certainly help animate that. But look, this political system is remarkably divided right now, and I don't think you can discount how those divisions impact our ability to make smart public policy. It will take truly transcendental leadership, I think, for us to get past this point and to use it to our advantage rather than to continue to fight over things we really probably won't ever agree on anyway.
Okay, thank you. Anthony, one of the things that both Lonnie and Lisa have talked about effectively is the difference between the federal level and going to our federalist system to state and local government. You are, of course, at the cutting edge of what's happening in California, the largest state in the union. We are at the moment not suffering from a major division within the state that is disrupting the capacity of the governor and the legislature to act. So what do you see happening in California in these terms, taking this moment of the pandemic and what we've all learned about what's been problematic about the healthcare system?
Yeah, I mean, I would actually, one friendly tweak to, I think, the discussion is I do think that the Affordable Care Act did actually provide more than actually, as much as the benefits of the Affordable Care Act, expanding coverage to tens of millions of people, putting new consumer protections, including for those for pre-existing conditions, et cetera, in place. I think one of the most important things it did is it showed that progress was possible. That in fact, for all the cynics, and there's lots of reasons to be cynical for the average American, that in fact a concerted, big, bold effort can actually have a result and actually have market results with regard to access in terms of giving people more rights, giving people more access to care. And I think we in California have then taken that to another step to say that, to I think Lanhi's point, which is that, if you have a conversation where we don't have the sort of politics that we see in DC, where we actually were able to have a bipartisan implementation of the Affordable Care Act, starting with a Republican governor and having at least some Republican votes here and there for the various pieces of several dozen bills that we helped work on to put it in place, then that doesn't mean that everything's perfect. Then you still have the very normal politics of inertia and an entrenched industry that doesn't want to, change, and five other, issues of process and procedure and policy and trade-offs and everything. But at least you could, and so it's not easy. The ACA was not self-implementing. It was, but that you can actually get the work done, and you can actually show tangible, real progress going forward. And I hope that some of the stuff that we're doing I would say if we have a different administration, to be completely candid, one that is less hostile to healthcare in general and California in specific, that we can have the continued funding and framework for California to continue to do that innovation, maybe built on some of the federal reforms that were talked about. I do think that if there, under a different administration, we would fix the family glitch and five other things in the Affordable Care Act. We would do the increased affordability subsidies that we're piloting here in California. We would allow for state innovations to go further in a variety of ways. I will caution, however, as somebody who is passionate about the role of states and what states can do, I would caution about what is possible in the alternative scenario where the federal government continues to be hostile and frankly seeks to strike down the Affordable Care Act either by legislative, administrative, budget, or litigation. And just to give you one factoid on this subject, to give you a sense of the scale for folks, the money that we get through the Affordable Care Act is about $20 billion for the Medicaid expansion, which covers nearly 4 million Californians, and roughly another $7 billion in covered California subsidies to help people afford coverage. That's $27 billion. If we lost that amount of money, if we had to try to backfill that money, California, the state of California, would have to defund all prisons and all funding for higher education, including UCLA and all the UCs and CSUs and community colleges, just to make up that amount, $27 billion. That is the scale of what we're talking about. So, you know, I am on the front lines of seeing what can states do, but it's hard to do that if we're having to make up that scale of financing and if we don't have the tools to do further things. You know, we have restrictions. We cannot regulate federally regulated plans. We cannot print money. And so we really do need that federal framework. And if we do that, then there's a lot that California can do. And I'm excited about that prospect, including serving with Dr. Hernandez on the Healthy California for All Commission.
Thank you, Anthony.
Mark, I mean, I think I was just going to say, I think this is an argument I've made many times to people who I would consider fellow travelers, which is that you can't have selective federalism. You either have federalism or you don't have federalism. And having a federal system means that you are dedicated to the notion that states can do what they believe they need to do. And the federal government should support that. Whether you agree with the policy direction or not, true federalism is a diversity of opinion and the laboratories of democracy, as Justice Brandeis once remarked in a famous Supreme Court decision. So, I think in that sense, I fully agree with you, which is the idea that if a state wants to pursue a policy objective that is within the federal framework, then that state should be permitted to pursue that objective so long as it meets the requirements of the federal framework. And that seems like a relatively simple concept, but there's an incredible amount of disagreement over even that component amongst people who should know better, frankly.
And Mark, if I could just weigh in on this point, because it is both state action, federal action, but we are 50 states. And so the reality is that we are also a country that is vast and very diverse, as Lanhi alluded to. And often national reform is based on an expansion of the learning from a state-focused reform. I mean, we are so big, passing big, bold ideas like the Affordable Care Act is hard. But as we've seen, it was based in part on other thoughts and evidence that have been sort of piloted or tried at the state level. And I've now lived in Florida, Maryland, Hawaii, California, and Ohio. Boy, are states different. And we really cannot, and I may not agree with some states' policies, but that is the beauty of our union, is that we have that federalism framework. The question is, what is the role of federal government in sort of creating at least the floor and incentives for reaching optimal health and optimal performance? And I think that's where, again, we can disagree on where that floor is and where the optimization will happen. But that's in the implementation. I personally would be very concerned about I won't even say that. I won't say that.
Well, I think one of what motivated this very important set of comments from you and from Lanhi is what Anthony pointed out, which is we've got a program right now that's got a lot of roots in federalism, and if it were to go away, there would be enormous financial consequences for all those states and what they're able to do. And so that's going to be one of the issues going forward about if we confront that kind of world. We've got about 10 minutes left, and we've promised some audience participation here. So I'm going to try to pose some of the questions from audience members. And my thing keeps moving around here. Where did that go? Okay. Well, there was one question that had to do, it seems to have left the list right now, but there was one question that had to do with something central to Rick Brown and something central to the Center for Health Policy Research and something central to everything you've all talked about, which is the role of research and policy. And one of the other things that's happened, and it's not just in the last 3 or 4 years, it's been going on for quite some time, and that is the denigration of research and expertise. It's happened in the past on both the left and the right, and right now we're in a moment in time, particularly with such a difficult issue like a pandemic, where there's just a lot of distrust in research and evidence and how you bring that or how one brings that into the policy-making process. Is there a way to pull that back, to return to a world in which there is greater confidence among policymakers and in the public of what is produced in the scientific enterprise or produced in the policy research enterprise, so that decision-making can't be all driven by research? It's got to be also rooted in democratic processes, but gives us a greater opportunity to produce more effective policy. Lisa, I've got you there. That's your front and center issue, so why don't you kick that off?
Our bread and butter, obviously, Mark. Thank you. First, like other things, I want to tease out that the American people have huge support for research. Every year, the Research America surveys, show that support by Americans for federal investments in research. This is largely driven by federal support for federal investments in the NIH, and the continually growing NIH budget, I think, is testament or evidence of that support for research. It's when you then go into an area of policy and its use of evidence, we have seen, and I am as concerned as many others, about the increased politicization of facts from research in a political and policy debate. So it's not all research that's being denigrated, it's some research. And I think that makes it more complicated. One of the issues for health services research that we focus on a lot, and we participated in the March for Science when that happened. Like you said, this has been going on and growing for years and has been accentuated by the fragmentation of our public square and the atomization of communities of sort of like interests, so that we're not talking with each other about things we disagree about. And I think research feeds into that, but it can also stop that. And I think the lessons, because I like to be an optimist for research, and particularly health services research, is people may not use our evidence because it's not timely and it's not relevant to the question they actually need an answer to. It's over here. And it's, health services research is an applied field. It has got to be driven and informed by the problems and the challenges faced by decision makers, whether they're a policymaker in Washington or a health system leader. So timeliness and relevance are critical. And the other point that I think the pandemic has shown us, has underscored, is our ability to communicate science is still lacking. We are not good. We have a lot still to learn about science communications. How do you communicate uncertainty? How do you not create whiplash in your audience as facts change over time because science and evidence is evolving? So I think we can do a better job as a research community to meet decision makers where they are and respond to their needs.
Thank you.
Yeah, Lisa, I think that's a really good point. When I was in government, that was one of the more frustrating things I would find would be that, when there was a policy question before you, oftentimes the research that you would get or what you would be hearing about was not directly relevant to the question at play. It was very good and well done research that certainly had implications for policy making at some point in time, but it wasn't particularly relevant to the specific question. And I think remembering that research is a wonderful endeavor, But if you're going to be in applied research, if you're not applying it to what's actually happening, it's of less use to the policymaking environment. It's not of less use to the enterprise of finding out what's, you know, what we know to be right and what we know to be wrong. But from a policymaker's perspective, it is very hard to cross that bridge sometimes unless you're led across it. And I think that engagement can be a very important part of this.
One thing that I would just say is that I absolutely agree with my co-panelists on this subject. And I want to commend UCLA Center for Health Policy Research and the other UC researchers that we have worked with over the years in being that kind of responsive and having that inputs with what's going on in the state legislature, what's going on in the infrastructure, and so that there is you know, relevant information that's timely that can have an impact on the conversation. You know, I think that the other piece I want to highlight is the opportunity to be grounded in community. That one of the themes of today is health equity, and I think sometimes when things are coming upon the ivory tower, that it's, you know, the supposition is that it's meant for one audience but not another. And so I do appreciate efforts to try to both get the information, you know, if it's survey research, that we recognize the diversity of our country and frankly our state. I think California has a leg up with other places because we just have the size and the scale to have, you know, with CHIS or with other things, with other surveys, to actually have statistically significant sample sizes of different ethnic groups, of different subpopulations, whether it be rural or otherwise, because even something small in California is still big. And so that really helps. But I do think that we always need to be vigilant about doing that, because, you know, because, you know, fundamentally people want to trust in the science, in the data, but that doesn't work if it's not representative on the front end with regard to how the data is being collected, and also on the back end about how it's being distributed, how it's being presented to the community, and if there is that give and take and back and forth. I think that's important for the legislators who represent those communities. I think it's important for the communities themselves, because trust is something to build up. And I will say that in this time when we have seen attacks on science, attacks on data, attacks on truth, you know, this is not just a two-sided fight, right? It is much easier to tear down than to build up, you know, that trust. And so, you know, the work of, you know, researchers and academics to do that work is going to be 3 times as tough as those who are just trying to tear it down, but it's worth it because that's our only salvation.
Thank you. Those are all very good comments tonight. Unfortunately, I'm looking at the clock and seeing that we are pretty much out of time and we have to move on with the program. But I did want to say, looking through the questions that others have put in, just so you know the kinds of themes that have been animating the responses to our conversation. One has been about the role of engaged patients, and to Lonnie, really, in a sense, would it be possible for there to be a system in which patients can really be engaged in that kind of consumer model? And my colleague Jack Needleman even brought up the old 1963 Ken Arrow article that I know Lonnie knows well, about the degree to which patients can be in that kind of capacity. Unfortunately, Lonnie, no chance to answer that question, just to let you know that it's out there. Another is that the concern about fear that people have about big change. As many of us know very well, there are advocates, for instance, for single payer who have gravitated to it with the belief that it's the only way out, and believe the only thing standing between it and enactment is fear. And I think that's a pretty complicated issue to raise, and something certainly to talk about. And the other thing that's laying out there is the courts. And with a redefined Supreme Court going forward, what will be the policy opportunities at the federal level? And that's going to be purely speculative right now, but something to watch. I really want to thank Lisa and Lonnie and Anthony for bringing their expertise and their experience and their different perspectives to these issues. It's so important. I wish we could go on for hours, frankly. I'm not sure everybody would agree with that, but I would certainly enjoy it immensely. So thank you very much for being part of this panel and joining this symposium in honor of Rick Brown. He would be very happy about what has transpired. And now I have the pleasure of turning over to Ron Brookmeyer, the Dean of the UCLA Fielding School of Public Health and Distinguished Professor of Biostatistics. He's a leader in the statistical and mathematical modeling of global public health issues, including path-breaking and much awarded work on the HIV, AIDS epidemic and the imminent Alzheimer's disease epidemic. Indicative of his contributions, he is an elected member of the National Academy of Medicine, a fellow of the American Association for the Advancement of Science and of the American Statistical Association. Dean Brookmeyer will introduce our final speaker of the day, a real pleasure, Dr. Robert K. Ross, President and CEO of the California Endowment. Dean Brookmeyer.
Great. Thank you, Mark. And thank you to our really terrific panelists. Good afternoon, everyone. I'm thrilled to be here with all of you for the 2020 E.R. Brown Symposium. Thank you to our colleagues at the Fielding School's Center for Health Policy Research for making today possible. You know, Rick Brown, the namesake of today's symposium and the founding director of the Center for Health Policy Research, strived to increase equity. He was an unwavering advocate for healthcare reform, and the change that he effected often started with one incredibly powerful tool: data. Data is the evidence we need to make change. CHIS, the California Health Interview Survey, which is housed at CHPR, was started by Dr. Brown. It remains the nation's largest state health survey and California's most comprehensive source of health data. It's a public tool that can be used by anyone to find health statistics about a neighborhood or region in our state. More than 1 million queries have been made to CHIS since the first survey was conducted in 2001. Those queries, that evidence, can be the tipping point that leads to policy change, to improving lives. The speaker you will hear from next is President and CEO of the California Endowment, which understood early on the power that the data from CHIS could have, what the evidence might do to markedly improve the lives of Californians, and that serve as a model for other states. The California Endowment was the inaugural investor in CHIS. The term visionary comes to mind when I think of Dr. Robert K. Ross. Dr. Ross understands better than most that improving health means addressing all aspects of our lives. It means expanding access to affordable, high-quality health care and making the connections between where we live, work, learn, and play. This holistic approach to fixing what ails us is vital to increasing equity. And Dr. Ross, in his role as President and CEO of the California Endowment for more than 20 years, continues to ensure that the investment of the endowment address the roots of the critical issues Californians face. The California Endowment serves as a nationwide philanthropic model of health investments for a good reason. It has time and again been ahead of the curve. As part of its Building Healthy Communities initiative, the endowment has taken a critical look at what our zip code means for our health. Where we're born, where we live, it can have a towering effect on how long we live. Under Dr. Ross's leadership, the endowment takes on these fundamental and foundational issues. In addition to serving as philanthropic leader, Dr. Ross has served as a pediatrician and a policymaker. Throughout his career, whether in the role of Commissioner of Public Health for the City of Philadelphia or Director of the Health and Human Services Agency for the County of San Diego, Dr. Ross has kept his firm commitment to addressing health equity front and center. Therefore, it is fitting that the American Public Health Association recently announced that Dr. Ross will be presented with the Sedgwick Memorial Medal, the association's oldest and most prestigious award. Dr. Ross joins a distinguished group of recipients, which includes Rick Brown, in recognition of outstanding leadership and accomplishments in the field of public health. It's my honor and pleasure to introduce Dr. Robert K. Ross. Dr. Ross.
Thank you so much, Bob. What an introduction. I have a feeling my comments are going to be shorter than the introduction, but I really appreciate that, Ron. Let me start with the ethos of championship. Congratulations to our Los Angeles Lakers, and good luck to our Los Angeles Dodgers. What we're talking about here, the topic is a championship of a different variety, and that is health equity. And how do we become champions of health equity through transformational change as a state and as a nation? Really inspired by the comments of so many of my colleagues and friends of years past, Sandra Ninez and Michael Rodriguez, Lisa Simpson. Lisa, great to see you. Anthony Wright has been a champion, whispering in our ear about our role in health reform for a number of years, and Mark, thank you for your work as well. I mean, what would Rick Brown say? Rick Brown would say the time is now, unapologetically and clearly, and I think that's the message. We define health transformation as 100% coverage with affordability, plus population health and public health approaches that addresses social determinants of health. And also, which initiative which didn't come up, but the competency and makeup of our health workforce, and all of that wrapped up in a racial equity frame. And so, when we talk about health for all at the California Endowment, that's what we mean. That's been informed by the communities we've served over the years, and I think it means four things going forward, all of which you've heard bits and pieces of already from the panelists. But let me just try and cobble them together into a final punchline for the day. So number one, COVID-19 reminds us that the time for meaningful, transformational change is now. I'll refer to Lisa Simpson's call for mention of a moonshot. And unfortunately, the grim reality we have is that the politics in DC don't allow for moonshot type bold moves, but we must find a way to endeavor to get to that moonshot of meaningful transformation and not just incrementalism at the edges of a system that's fundamentally broken and way too expensive. Number two, we need to pivot right after this election. And so for California, it means, and I understand, all of this is much better, as you've said, Anthony, with a federal partner than it is without one. But we must aim for boldness and transformation, either with a federal partner or without one. And the without one is a taller order, but we can no longer just settle for not very meaningful changes that represent some incremental compromise in the middle between the Republican Party in Congress and the Democratic Party in Congress. I'm talking about meaningful transformational change. Unified financing mechanism, whether you call that Medicare for all or single payer or some version or some variant of that. That's certainly what we mean by transformation and not just nibbling at the edges of a fundamentally broken system. I would say at a minimum, and both Anthony and Sandra and I are all on the Governor's Health for All Commission, but we'll see where that goes and picks up after the election is done. But I would say at a minimum, the low bar is at a minimum a public option, at a minimum. And anything less than that, in my view, would fall short of the kind of meaningful transformation and systemic change that we need. Number three, and thank you, Lisa, for mentioning it, asserting racial equity and racial justice and all that we do and apply racial justice and racial equity to transformation and reform efforts. And number four, let's be clear about how this is going to happen and how it's not going to happen. No offense to the editorial board at the New York Times or articles that appear in the Milbank Quarterly or the New England Journal of Medicine or Stanford Social Innovation Review, or even stuff coming out of Harvard or UCLA public policy schools. That's not where transformation is going to come from. It's going to come from people power. It's going to come from a demand of, quite frankly, an infuriated public who demands and expects accountability for meaningful change. And so you mentioned in your introduction of our work, thank you so much, Dean, our recognition of the role that data can play, particularly through Rick Brown's leadership in driving policy. I would say that 15 years later, our wake-up call has been about people power. If we learned anything from building healthy communities, 10 years of work, $1.5 billion spent to see structural and policy changes at the local level to advance health. That's a people power driven enterprise. Data has been used to amplify or support the experiences of impacted communities. But as you know, in closing, I would say Martin Luther King Jr. and John Lewis, civil rights icon John Lewis, talked about a vision for America of a beloved community. Both have recognized, those individuals recognize the role that health plays in getting to a beloved community, and a beloved community defined as real sisterhood, brotherhood, kinship, inclusion, a sense of opportunity and peace and wellness and justice for all. And having a health system that is affirming of that vision and acts in concert of that vision is not the health system we have today. And Rick Brown would say to us right now, he would say that 216,000 people have died to prove that our healthcare system, both our public health system and our health delivery system, does not work. And if we don't use this moment for transformative, meaningful change, then those 216,000 deaths will have gone for naught. We lost 50,000 Americans in the Vietnam War. So we are now fourfold past the loss of the Vietnam War with COVID. And we are moving closer and closer to the mammoth losses we saw in World War II, which is 216,000 deaths, 290,000 deaths. And so from a standpoint of accountability, we just simply cannot rest until meaningful transformation happens. And meaningful transformation is going to happen through grassroots engagement of consumers and patients and the most impacted and the most vulnerable. We know that COVID-19 has impacted the most vulnerable among us in our nation, mostly Black and brown, but if you're in poverty, if you live in the wrong zip code, then COVID is affecting you the greatest. And so I don't know what other wake-up call we need than this pandemic we're dealing with right now. And if we revert to a public discourse and policy discourse that is about changes at the margins of a fundamentally broken and way too expensive system, then we will have failed. And so for us at the California Endowment, we are thinking more about transformation. We are thinking more about boldness. We are thinking more about people power, advocacy, advocates, funding the good troublemakers of the kind that Anthony Wright represents, that John Lewis spoke to, good troublemakers, advocates, activists on behalf of that vision of a beloved community. And so I think it's going to require all of us to take a look at ourselves in the mirror and raise our game, whatever that means. Ourselves included at the California Endowment, myself included as CEO, that whatever we've been doing over the last 20 years is not going to get us to where we need to get to. And so we'll take a good hard look, and our ears will be open at the California Endowment about what that means for us and our investments, our projected $1.5 billion in over the next 10 years of investments, but how we invest those dollars around the idea of funding those good troublemakers, of funding advocacy, activism, and a meaningful, accountable demand for change and transformative change. That's what we'll be about. And if it takes us 3 years to get there, so be it. If it takes us 30 years to get there, so be it. But never to lose eyes on that prize. And I just want to thank each and every one of you for following the chat. We're going to be funding advocacy, organizing, and activism on behalf of transformational change. That's what we're going to be doing at the California Endowment, and doing it increasingly over the years to come. So with that, I just want to thank our colleagues at UCLA. Thank you, Mark. Thank you, Dean. And thank all of you for your leadership in this area.
Thank you, Bob. Thank you, Dr. Ross.